Okay, good morning, everyone, and welcome to the Adults and Health Scrutiny Committee. Before we start this morning, we have a very sad, we obviously know that we've lost Tony Robbins. So I'd like us to have a minute's silence. But before I do that, I'd just like to read a passage about Tony. Tony passed away at home on the 8th of February, 2026, 69, very young man. Tony was a Liberal Democrat member serving Somerset Council in the Mendip Hills Division since his election in May 2022. He contributed to a wide range of communities, including the Planning Committee, East, Licensing and Regulatory Committee, Adults and Health Committee, and Full Council, always bringing diligence, balance, and integrity to responsibilities. His commitment extended his community life. He was elected to Wales Council in 2007, holding many roles, always determined to support and strengthen the historic city he cared so much about and he called home. They included serving as Mayor of Wales from 2010 to 11, and most recently as the Chair of the Council's Finance Committee. Councillor Tony Robbins was known for his warmth, humour and humanity. He would be hugely missed by all of us, Somerset Council, and we send our condolences to his wife Sylvia and daughter Georgie. And obviously we're very, very, very sad. Does any other member wish to add to anything I've said today? You know him?
Just for,
Yes, sir. Yeah.
just for. His colleague on the minute, he stated, I knew him very, very well. We used to catch him every Monday morning in Wales. I've not got a lot to add, but just sort of to say, I miss him a lot. I miss his warmth, his humour. I spoke to him a couple of days before he died. He seemed in good health and he wished me happy birthday. So I miss him greatly, as does everybody in the Wales area.
Councillor Slade.
Thank you. I didn't know. I'm grateful to have this opportunity to reflect on Tony. I would have been giving him a lift today because he would ask, and it was always such a pleasant journey, stimulating journey. And Tony was a listener. People think of him as quite quiet, but it was just that he was a listener and he asked lots of questions and was always interested in things. But he just was what people say, a really good person, and I'm just so gutted for us as councillors that we've lost a really good one. But obviously my heart goes to first and foremost to his family and his close friends.
Thank you very much for that. Thank you. Everyone else? Okay, if I could just ask you if you could stand for a minute's silence, please. Thank you very much. Thank you. Okay, so I'd like to welcome everybody, including members of the public, and welcome everyone online.
Actually, just using
You know, I'm Jo Slocum, I'm the chair of this committee. There are no planned fire drills today. In the event of a fire alarm, please exit the building through the main reception after me. If anyone present requires assistance in exiting the building, please let the Democratic Services team know. The assembly point is on the grass outside on the job centre. The agenda pack with papers is available via ModGov or directly from the council's website from the link which was sent out to members. So I think everyone knows that. I'm requesting other members and officers turn off the microphones and videos. And please remember to turn on the microphone and video when you speak. This helps with background noise, call quality, and anything disrupting the meeting. When I invite somebody to speak, could you clearly state who you are, the benefit of anyone who's listening to the meeting, so they can identify you and what you're going to say. Can I remind members to use the chat function solely for business? Otherwise, it's distracting to others. And the agendas are viewed electronically. I've said so members and officers refer to page numbers from the appropriate agenda pack to assist all present in finding the appropriate information. So that's quite clear. So I invite, for item 1 is invite Jamie to list any apologies.
Thank you, Chair. Good morning, committee. We have received apologies from Councillor Pearlstone and from Councillor Woods, for whom Councillor Whale is substituting, and committee members Councillors Govia and Power are online, Chair. Councillor Power has his hand up, Chair.
Oh, Councillor Power, would you like to wish to speak?
Thank you, Chair. I'm sorry to be, I can't be in the room today. But Lucy has just contacted me, so she is on her way. She's just stuck in traffic, but I don't know because I can't see if she's in the room now, but she is on her way. Thank you.
Thank you so much for that, because Lucy never misses. Oh, and as we speak, she enters the room. Welcome, Councillor Trimnell. Welcome. Thank you so much, Tom. Thank you. Lovely to see you, Councillor. I'll let you settle in. We'll just carry on and welcome. Thank you. Sorry about the traffic. Thank you. Okay, item 2 is to approve the minutes from the previous meeting on the 20th of November and the 15th of December. Are you all happy? It's a true record. No dissenters. Everybody good? We'd like to thank Councillor Whale for standing in for Councillor Woods, which is really appreciated.
Yeah, I believe it is for a number
Yes.
of meetings, so I don't know whether that's voted or not. Certainly for the next one.
Yes, yes, and thank you. It's not very important that Helen knows and Jamie, so that's very kind of you. Thank you very much. Thank you. Okay, item 3 is declarations of interest. This is to invite members to declare any interest, to make them aware that a list of committee members' personal interest as members of district, town, parish councils is available on the website. Do we have any declarations of interest? None? Good. Sorry, that's not the right thing to say, but you know what I mean. Item 4, public question time. We have one question from Sarah Baker. Although Sarah is unable to attend, oh, she's actually online. That's wonderful. Okay, so I invite Jamie Jackson. So, no, I'll invite Sarah. Sarah, would you like to ask your question, please? Welcome to the meeting.
Thank you. Thank you. So I couldn't attend in person. This first question has been actually taken from Paula McGowan's social media page. Paula McGowan OBE runs Oliver's campaign hashtag. Paula recently contacted the top 30 organisations receiving hundreds of thousands of pounds in taxpayers' money. Several of these organisations have previously been investigated for serious abuse and harm, involving people with a learning disability and autistic people. And they are aware of some of those, we are aware of some of those companies in Somerset. They were each asked one simple question. Have you started rolling out tiers 1 and 2 of the Oliver McGowan mandatory training on learning disability and autism? This training is statutory. It has been co-designed, evaluated, and is delivered by people with lived experience, experts whose contribution must be recognised and fairly paid at band 5. These organisations are funded by taxpayers. Families and the public deserve transparency. Paula has listed some of the organisations, and we have listed the ones that we recognise are in Somerset, and we're unsure what kind of level of service they are providing. What auditing and monitoring does the council carry out to ensure essential learning does and has taken place with all staff members? How is Oliver McGowan mandatory training incorporated into the autism strategy? How is the Somerset NHS working to strengthen the understanding of learning disability and autism in all departments of our county hospitals and services, GPs and other commissioned companies? We have also identified other providers that were missing from the list, and concerns are being raised about their lack of understanding on autism. And how will the officers ensure all providers are commissioned directly or indirectly comply. These companies are not on the local offer. Originally, the adult portal that was tested with residents was to create a shopping basket of suitable advice and providers. It was never the final product that was released, and the Children's Department were forced to contribute a large sum to ditch their temporary local offer provider to join the adults portal. This end decision in 2015 was never consulted on, and having these on the local offer will help transitioning to adult services. So we're going to have a lot of young people who do need to transition over, and those who have council or privately commissioned direct payments. However, this essential information on the NHS Health Connections Mendip website that appears to duplicate what was meant to be on the council website and the duplicated Well Aware website that the council refused to support during 2015 to 2018. When will the NHS and our council work collaboratively together, please? Thank you.
To the response from Sarah Wakefield, the League member for Adult Services, Housing and Homelessness, and also League member Emily Fulbrook, Service Director, Adult Social Care, will speak afterwards. So Emma, so over to you, Sarah.
Yes, this question actually involves both the NHS and adult services at Somerset Council. So it has been, the reply has been drafted by both of those together. The NHS person isn't able to be here today, so we are going to give the reply. I'm not going to do it. One of the officers can read it out. It's going to be Stephen Miles. We're going to read it out. Okay.
Yes. Good morning, committee. My name's Stephen Miles. I'm Head of Service for Working Age Adults Commissioning within Somerset Council. And as Councillor Wakefield said, unfortunately, NHS ICB colleagues were not able to join the meeting today. So what I'm about to say is being written on behalf of us both. So from the 1st July 2022, the Health and Care Act included a duty for ICB and local authority care Quality Commission regulated service providers to ensure that each person working for the purpose of the regulated activities carried out by them receives training on learning disability and autism, which is appropriate to the person's role. In Somerset, there are around 30,000 NHS staff, and that's a head count, who are required to complete Oliver McGowan mandatory training, 80% of which equates to roughly 24,000 staff require Tier 2 training, including public facing and certain commissioning roles. The remaining 20% require Tier 1. Using available funding from NHS England, Somerset ICB built an infrastructure locally to recruit and train facilitators and experts with lived experience and establish a local delivery model. Tier 1 started in June 2023 and Tier 2 started in July 2023. NHS England funding stipulated that it should be used for training NHS Care Quality Commission regulated staff only. Social care did not receive any dedicated funding from Skills for Care. As a result, NHS Somerset ICB worked collaboratively with Somerset Council from the beginning to design and deliver an offer across the integrated care system. In order to improve access for primary care, we offered to deliver Oliver McGowan mandatory training on site using their already allocated training days. This proved successful due in a large part to the flexibility of our trainers and experts and their support workers to travel and work in many different venues. To date, we have trained around 99% of the primary care workforce. We also offered training to Signet Taunton, who completed it for staff on their learning disability and autism ward. Where places were available, it was also offered to the local authority workforce and Somerset social care providers. To date, we have trained 22% of our workforce on Tier 1 and 41% of our workforce on Tier 2. Unfortunately, we are currently not in receipt of any funding from NHS England. Hopefully, further funding will be released in the next financial year once we reach 30% on Tier 1 within the workforce, although this will have to be match funded. All system partners will have to consider commissioning bespoke solutions going forward, and we hope there will be reciprocal support from our system partners for the NHS in case there are training places available. With regard to adult social care providers, the service specifications for the specialist adult support in Somerset dynamic purchasing system, which will use to commission care and support for adults with a learning disability and or autism, specifically references Oliver McGowan mandatory training. Compliance with this is monitored by the adult social care quality assurance team through quarterly returns and visits. Of the 3 providers referenced, only one, CareTech, through a subsidiary, is registered on the dynamic purchasing system, having done so in December 2025. Somerset Council's adult social care learning development team is also currently in the process of considering options for commissioning Oliver McGowan mandatory training in the future. With regard to the inclusion of the training within strategies, we wouldn't normally reference specific training courses within a strategy, as we'd be looking to ensure that there was a suitably skilled workforce within the local system overall. However, as we've said above, arrangements are in place to monitor compliance, and that was the end of the response.
Very much, Stephen. Thank you. I hope Sarah Baker, you will have had that response. I'm sure you'll get that in writing as well. Okay, so that you can digest that. And thank you for it. Well, just to let you know, we did have another question that I'm afraid was out of the time. There is a time slot, and that was out of the time. So that will be given a written response to it. All questions are treated very importantly, but they need to be in time for the meeting. So that will be dealt with. No problem at all. Thank you. Okay, is anyone else? So we can move on now to item 5. This is another exciting moment for Jamie. Doesn't get the highlight very often. And the Adults and Health Scrutiny Committee Outcome Tracker, which many of us are not sure what that is. So we look forward to hearing from you.
Thank you, Chair. It's going to be a fairly short highlight, but one of the aims of the recent scrutiny review was to ensure consistency across the piece between all 5 scrutiny committees. One of the areas that we need to introduce with adults health is what we're calling an outcome tracker, which is where if the committee makes recommendations to either executive or full council or as items on the request on its forward work programme or something else that it wants to explore in greater detail, we log it effectively on an outcome tracker. The committee then gets to review that outcome tracker at each meeting. And once the item has been completed, it then hopefully disappears off the outcome tracker. I apologise that I didn't have time to complete a sufficient outcome tracker to be published this agenda, but I suppose it was just a bit of a forewarning that will be coming to the next agenda. And again, it will be an opportunity for members to discuss. So the intention is that that will sit at the beginning part of the meeting at item 5. And then the work programme will be the last item on the agenda, which is where members will have the opportunity to suggest items for the forward agenda, particularly based on discussions that they may have had that day.
That's absolutely perfect. Is everyone happy with that? Everyone understand? Councillor Bailey.
When will the outcome tracker be circulated with all the papers?
It will be, yeah. The intention will be that it will always be published with the papers in the same way that the forward.
This is just a precursor into it. So the next time we're ready to go. Okay. So just giving you plenty of warning. Thank you very much, Jamie. Item 6 is our defibrillators in the community. This is page 23 to 26. And I would like to invite, and thank you so much for our 3 NHS, very, very busy people. So I really appreciate this. George Pemble Vincent, he's the area head of volunteering and community services North and the Southern Western Ambulance Service NHS Foundation Trust to provide an overview of the report. And you other 2 gentlemen, I presume, are as well. If you forget anything, George, okay? Is that what it is, or?
Chair, would you mind if I?
You could do a double act. I don't mind what you do, but it's a very interesting point. So thank you very much.
Okay, Chair, thank you very much for having us today. This for us is a really important topic. It's about how we create a county of lifesavers, of members of the community who can act when seconds matter, when seconds are the difference between colleague, a loved one, friend, surviving an out of hospital cardiac arrest, or so there is nothing more important than that for us as an ambulance service, and we particularly look forward to working with colleagues from across the county on how we ensure that Somerset leads the way in enabling people to make those kinds of interventions, very basic interventions that we know really save lives in the minutes before advanced life support through our colleagues arrive on the scene. So George is going to take us through the paper. He's very much a subject matter expert. And then we'll be very happy to take questions and really talk with colleagues about how we can create a county of lifesavers.
Thank you very much.
Thank you. Morning, Chair. Morning, Committee. So the first question on the paper was around community defibrillator location and gaps in coverage. We have a really good, strong number of defibs across the Somerset area and including across the whole of the Southwest. The Somerset figures are actually already higher than most areas, but we know there are defibrillators out there that are not registered. So our ask to the committee and to communities is if you see a defib, check it. Everyone can check a defib through defib finder, ensuring that it's registered and available in the service. Means that in emergencies, we can direct people to it. So the next question was around sort of the gaps in coverage. Our aim would be every street corner can have a defibrillator. And the ask to the committee would be, when looking at new buildings in the areas, new streets, think, can a defib go there? Can we increase it, not just in areas that currently have gaps, but any new areas that are in developments across Somerset and the wider Southwest? So we know that there's a good uptake of defibrillator usage. There are some barriers, and actually these barriers can easily be overcome by everyone. One of the biggest barriers is locked defibrillator cabinets. We strongly advocate unlocked defibs. We treat them like a fire extinguisher. They should be easily accessible and ready in an emergency with no barrier to any rescuer. Anyone can use a community defib. And if they don't know how to use it, our call handlers are specially trained to talk people through step-by-step guidance over the phone. So if you see a locked cabinet, think, who owns it? Can we get it open access? Can we remove the barrier? Unfortunately, locks fail mechanically and unfortunately incorrect codes we put online. The Research Council guidelines recently updated and are now strongly advocating unlocked cabinets as well. So that's a new national push to try and help stronger collectively get us to get all defibs open access. The next one is around what is the data telling us. So the data tells us that every second counts. And that's why these are such important things to look at when we're looking at getting defibrillators available. Let's remove unnecessary barriers. Let's get the defib to that patient at a timely matter and make sure that we can improve outcomes. The next area was around our volunteers. So our volunteers are strongly working not just to respond to patients, but to get these community defibs available. We're working with the circuit as the national defibrillator provider across England, and we are going out to visit defibs that have not been status checked recently to make sure that they are ready and available to communities. Likewise, we're going out to ones that have been deployed and not yet returned back into service to make sure that we can reduce that time gap, get it back available again for the community. I welcome any questions around the paper. Otherwise, I will finish there if that's okay, Chair.
Thank you very much. Thank you, George. Lucy Trimnell, Councillor Trimnell.
Thank you very much for this. I found it really interesting to read. Are we going to be talking about the community first responders separately, or is that part of the discussion now?
Okay, I'm more than happy to talk about our community first responders. So across Somerset, we have an amazing county of 70 current active community first responders. They provide a significant contribution towards our response times. So one thing that you would have seen in the report is that over the last 8 weeks, they've contributed 39 seconds towards our Cat 1 response time. These are your local community heroes. They are the lifesavers. We are always working to increase our availability and coverage of community first responders. We run as many campaigns as we can to recruit, not just to areas that we know currently have gaps, but to any area that we'd like to set up a new volunteering scheme. And these volunteers, alongside the community first responders, are also going towards one of the other elements that was on the question around resuscitation training. So we are now bringing in volunteers, which are our community training volunteers, and they will be going out to communities to remove that health inequality of access to training for people who can afford it. These are volunteers delivering free life-saving training to communities to help raise awareness of how to do CPR and raise confidence in using a community defibrillator. So our community first responders are not just saving lives directly, they're indirectly saving lives by teaching the skill to anyone, and a skill that anyone can do.
Stanley.
So I have, I mean, firstly, it's an amazing sounding scheme. And when I first read it, I thought 39 seconds isn't much because the size of the county, you would imagine that you would be taking minutes off. But I know that every second counts when it comes to these things. But I wondered, are there gaps in areas for community responders? I'm not aware of them, to be honest with you. I'm not, I presume they just drive in their own cars and they don't have a uniform and they just, you know, so I wonder whether the awareness is there in our community. So that's my first question.
Yes, certainly, and thank you for the question. So to answer that, we're always looking to increase our number of volunteers. Our volunteers provide time flexible to them around their working commitments and around their family commitments. So their availability is very much based on their ongoing heavily committed lives. So we like to make sure that we've got as many volunteers as possible to increase our coverage. And we try to advertise all of our recruitment campaigns online. We found social media is a great way to spread that. And what I'd like to welcome you to do is share within your communities. When you see our efforts going out, get them spread out across the communities. What we want to try and do is reach into those networks and reach into communities that want to volunteer to support us. So we would welcome introducing volunteer schemes into almost any area across Somerset. We try to completely subscribe our course to capacity to make sure that we are getting the most out of every session. So we welcome as many applications as we can get into any of your areas.
I'm sorry, I've got two more questions.
Well, yes, okay, quickies.
Thank you. So the first one is, do you have to fundraise for this to pay for the training?
No, so we work really closely with South West Ambulance Charity and we receive grants from NHS Charity Together. We fund all of the equipment and training for all of our volunteers. We don't ask for any sort of financial contribution. We also cover expenses for mileage depending instance as well. We don't like our volunteers to be out of pocket and we like to ensure that as a service and with our support from our charity that we can get the most out of our volunteers and support the community as well, there being any financial contribution needed.
Thank you. And then finally, on the defibrillators. So as far as I'm aware, I mean, I go to my parish council meeting. Lots of times, many of them are discussing, should we have a defibrillator? Should we have another one? Is anyone checking them? There are some issues around those responsibilities, I think, for the maintenance, which sometimes cause a problem when one parish councillor leads, for example, who had the responsibility of doing that, or a member of the community who was nominated. And so I just, you know, we've also had them in schools, but I presume who knows are the kinds of ones that are locked away, the ones that people can't access 24/7, as it were. And my big concern is there's one in the small village that I live in, because I represent Bruton, but I live in Pickham. It's been vandalised and nobody knew it had been vandalised. People didn't know for quite a while. So if somebody had gone to rely on that machine, then they wouldn't have been able to use it. And so I wonder I don't know whether the box is locked or not, but I guess the locked boxes is to stop vandalism and casual sort of use. And we're now looking to relocate it because it's on the site of a building that's no longer in use. So these things are really difficult. And I just wondered what your comments were in terms of security of these devices.
Absolutely, I'm more than happy to answer that. So to cover off the vandalisation of locked boxes, our last data showed that we had more defected locked cabinets than unlocked. We very rarely see our unlocked open access ones taken away and damaged. A lock symbolises that there's something in there of importance, so people normally break in, then realise what it is. To answer your other questions, we've been working with the circuit to ensure that all schools are registered as available. So during opening hours, we direct people to schools if that is their closest defibrillator. We also work with them to look at removing it from their reception from a 9 to 5 Monday to Friday defib to installing it in a cabinet on the outside of the school. So when there is out of hours holiday clubs, weekend sports clubs on the field, that defibrillator remains available, not just to the users of the schools and the grounds, but to the whole community. And your final question around sort of the defibs that have been put in place in not checked, and we use the terminology of an orphan defib. So one thing we look at with the circuit is any defib that's not had a status check registered within 100 days, we will then look at to work out who owns it. Are they going to check it? Our recommendation is a visual daily check, and at least a minimum of a once a week check to make sure that defib is rescue ready, to make sure that it's not going to fail in an emergency. What we will do is we will reach out to the person who initially registered it to see if they are still looking after it and maintaining it. If we're unable to get hold of them, we've got really close connections with local lion groups, with local community groups, and we can signpost those defibs to be reunited with a new guardian. And we work with charities across the Southwest who are looking to fund defibrillator replacements and replacement defib cabinets for those that have been vandalised. There is support as well through the Southwest Ambulance Charity, where we look at supporting funding to replace any lost items.
Thank you. I'll be quiet now. Thank you, Chair.
No, excellent questions, Councillor Chimney, as always. We do have a number, I've got people online, I've got a couple now online, and but I'd like to go to Councillor Hobbs in the room first and Councillor Bailey afterwards, please. And Councillor Wale.
Thank you, Chair. And it was me who wanted this brought to committee because it's something I'm passionate about, and mainly because one of my friends had to go to a locked cabinet. So while her husband is there breaking ribs, they did save the person and the first responders jumped. But while my friend's husband is breaking ribs, saving the life of a neighbour, she's driven 2 minutes away to a locked cabinet and is on the phone for over 4 minutes being asked questions she can't answer, such as, is this person responsive? And she's sort of politely going, I don't know, I'm doing the right thing. My husband's gone, first instance, as you guys would say, first person breaks ribs, trying to save the life. The second person gets defib. So poor Sue is getting the defib, not able to answer questions. Luckily, the person was saved. So this is why I'm passionate against locked cabinets. I'm glad you guys are as well. I threw on my engineering contract for Tavis, secure one for the community on the Meadow Hills. Just to sort of lend money for a non-locked cabinet is not. Inside the ring. So notice one in my division I found is in a locked cabinet on a pole. It's not on the circuit. So I need to address that. Do I register it myself? I'm the one I just got installed. I'm the guardian for it, so I'm well aware of checking it. How do we go about changing the lock cabinet? I mean, lots of those big green cabinets with the keypad on the wall. Do we raise the few £100 to change them to one of the big yellow cabinets like I've got, which are unlocked? Is that the best way to do it? So I'd like to look at the way forward. My village, my home village of Priddy, where my mum lives and where I grew up, is well covered for defibrillators. We have, I think, in a 2 mile radius, we've got 3 or 4, but the one I've got is the only one in an unlocked cabinet. So I'd like to know, and maybe Lucy would as well, in terms of taking this for unlocked cabinets. As far as vandalism goes, Lucy, I live in Shepton Mallet. It's not a den of iniquity, but we do have the odd case of vandalism in the park. We've got 2 coupling house defibrillators. I've had to use one. Sadly, it wasn't successful a few years ago. I think in the 7 years they've been there, one is on the side of Morrison's in town, and one is on the side of the toilet block in the park. I think I've only been tackled once. And I'd rather see maybe have to replace the defibrillator for £1,000 with some perhaps pinch if somebody died through probably inaccessible.
Yeah.
Do you want to respond to that, or do you want to wait for all the questions, or
Happy to
answer it? Yeah,
answer that one.
Yeah.
So look, I think the important thing is how we think about defibrillators. We don't blink twice about thinking about having a fire extinguisher in every room that's not in a locked cabinet. They're there, and we take the risk that, of course, if someone does something we wouldn't want them to do, and whether that's vandalism or theft or anything else, then of course we take that risk and replace it. We wouldn't lock away a fire extinguisher, and we very much would like people to think about defibrillators in the same way. The other thing that's important, it sounds like you, Councillor, have got this, is lived experience. People think about defibrillators once they've had to use them. So there's something here for us about how we engage all of our communities in thinking about this before you need to use it yourself, or a friend or a neighbour needs to use it. It needs active thought about where it's going to be, how it's designed to have easy access, who's trained to use it. These things need active thought and planning. And we are open to working with any communities to help them get into that space. George will answer the question, particularly around cabinets, because it's outside of my area of knowledge. But I think the key thing here is, if we take away nothing else from this, it's thinking about an AED in the same way you would a fire extinguisher.
Thank you, Councillor, for the work you're doing to promote unlocked cabinets. And I agree, it is something that really needs to be done. And for your work getting additional DFIB and Priddy, as a local resident, I'm really pleased to see the number of DFIBs going up. In regards to changing the cabinets, a lot of providers can just sell the lock to change it to an open lock. What some communities have done is written the code on the cabinet. Now, that doesn't stop when there's a mechanical failure of the actual lock, but it does help reduce that time delay on getting into it. So sometimes there is that cost-effective solution of putting the code as easy accessible, or instead of replacing the whole cabinet, just replace the mechanism to an open lock.
Thank you. Councillor Bailey.
Thank you, Chair. John Bailey, Martock, Somerset Councillor. My first question or comment really is about the schools that you raised. And I'm pleased to hear that you seem to be actively working with the schools, because they're now, where they were community-based and available, now they're surrounded by fences. So have you got an active policy to get those outside the fence? So they're now a community resource. That's the first question. So that's about the DFIBs. And the second one was just about I'm sure we'd all like to actively work in helping to build up your range of your cover of first responders. And I find it useful to know where the shortfalls are on the gaps in your coverage, and work towards that, because I don't necessarily know when a first responder retires. I know that they're there, but not when they're not there. I mean, so that information will be useful where you've got gaps in your coverage. So one about DFIBs, one about first responders. Thank you.
Thank you. So, Councillor, if we take those in reverse order, and I'll just speak to the CFR point. So we know genuinely seconds matter when it comes to out of hospital cardiac arrest. All of the international evidence points towards that being the case. So the truth is, we could do with more lifesavers in every community. So whilst we have 70 brilliant, and they are awesome volunteers, in a county the size of Somerset, that is a start, and they are brilliant, but we need far more in every community. So we would look to work with every community in Somerset to see how we could increase numbers further. And this isn't about rural versus urban either, as is often thought about for CFRs. Genuinely, this is something that affects every community, every neighbourhood, and every household. Is how we get hands on chest in the event of an out of hospital cardiac arrest, in ideally within the first 30 seconds. So to do that, we genuinely need a lifesaver on every street corner.
Thank you, Councillor. In regards to the schools, so approximately 18 months ago, the Department of Education provided the defibrillators to every registered school across England. And one thing they did with the guidance for installing those was to put a request in that, although it's not mandated that they make them publicly available outside, their strong recommendation was to make sure they are fully accessible and publicly available. So what our team has been doing is cross-referencing all schools registered against those on the circuit. And we have been individually contacting each school that's not currently registered on the circuit to see if can we get them to register it to become available, and will they put it outside and make it publicly available. Whilst the defibrillator is owned by the school, we still take that responsibility to work with them collaboratively to try and make it a community life-saving access defibrillator.
Thank you.
Thank you very much. Councillor Ware.
Yes, thank you. Thank you, Chair. Well, it will be a question, but a statement first, really. What this is, this organisation, it's a great opportunity for us as councillors and us as parish councillors who are, and the public and the service here to actually get involved. And that's the main message, really. I mean, for example, when I was town councillor and district councillor, I managed to persuade
town council and the then county council and a lot of fundraising, and we bought a car for our first responders in charge of a local area. That was in 2008, I think. And that car is still going, and it's still been, because I actually talked to the first responders, and they were using their own cars, doing their own insurance and their own petrol, I think, at that time. It was a long while ago. And so I thought it was absolute nonsense. But so anyway, so we've got a car for the first responders. That was the first thing. Then we get around to DFIB. And for example, in my village then, the telephone box outside the pub was coming available for £1, which we purchased. We then set up a group, and actually my wife did it all, but went around knocking on doors with a begging bowl, and got enough money together to buy the defibrillator, which I can't remember how much it was now, and it's just coming up for replacement, which is £2,000, I think, roughly for anyway, whatever. And so it's a community effort, this, and it's really, really important, obviously. And so my wonderful questions after that is how much is the new defibrillator? Well, I think it's the inners of the thing has to be replaced every, is it 4 years? Something like that. And also, I'm more for the committee here, really, funding. They aren't cheap. And so it is something which we should look at as councillors to get grants towards, etc. And so that's my 2 points, really: money and replacement.
I think that's taken on board by all of us here. You don't need to respond to that. I think but if you want to carry on, Julie.
Thank you, Councillor. I just wanted to thank the work that Chard have done. So Chard as a community have got one of the largest number of community DFIBs, and the work with the community first responder car as well. In regards to the cost of replacement, so each defibrillator has a different warranty timescale. A warranty is the manufacturer's recommendation. It doesn't mean that the actual unit expires or stops working. And as long as you are doing weekly checks and it remains rescue ready, then it is still suitably useful as a defibrillator. In regards to cost, we strongly recommend communities to look at types of defibrillators available. There are some models where the batteries and the pads are a combined unit, which means if the pads are used, there is a higher cost to replacing both the pads and the battery at the same time, where other units, you can get the consumables as a separate battery. Normally they last 4 to 5 years, and then the pads can be replaced ad hoc as required. So there are different models that will bring costs down.
I'll come back. That's very interesting, because I said my wife is at the moment trying to raise funds to have the thing replaced, and she actually got me out of retirement to a gig the other day. So a bit like the Rolling Stones, really, keep coming out of retirement. But we managed to raise about 800 quid, so that was good. Thank you.
He is actually one of the Rolling Stones, but he's kept under wraps. Before we go to the next councillor, I just want to pick up on a point. We've got many, but I think the thing that makes me feel embarrassed slightly, I know you're out there, I know you're doing good. We bought a defib in my ward. We want to buy another one for the other part of the ward. And you're not accessible. You're not easily accessible. You have to remember, not everybody is online. Volunteers are not all online. We've still got this amazing amount of people that actually, probably would contribute to the charity, would contribute to the wonderful work you do, but they don't know about you. And I think you do need to up your game not in your physical game, but in the marketing. I think you need to do something to let us know that you're there, to remind us of what you're doing. We know that you're out there, but we don't actually know how many times you're out there. What are you doing? And I think it would be really good for members of the public to, because I mean, you say you go on social media. I've never seen anything on social media, and only complaints about me. But you know what I mean. And I think it would be really good for us to see you, to see where we can get hold of you. We want to buy one, excuse me, but we don't know how to. We're looking at it, but those are things I think that'd be really good for everyone to know about. And also being a trainer, I would just think it would be wonderful to be a counsellor, be called to somebody put your red cloak on or your blue cloak or whatever, run down the road and save someone's life. What a wonderful thing to be able to do. I did the training many, many years ago. Don't feel like confident now, but I would love to do it. I'd love to be able to be trained and think that, you know, there's an expectation. And I just think that must be an amazing feeling to think that you've saved someone's life. So I just would like you to take that on board, if that's okay, please, you know. Okay, I'd like to go to Councillor Cameron. Cameron, please.
Thank you very much, Chair. I am one of those community first aiders. And so therefore I do recognise the importance of defibrillators. My question, however, moves beyond defibrillators. Defibrillators assist us in maintaining life at the scene, as colleagues know. The real question here that I would like to pose is around ambulance response times. We know the categories 1 through to 4 and the response times therein. We know that those are not necessarily always achieved, those standards across the county. And indeed, in recent weeks, one of my residents suffered from acute carbon monoxide poisoning and was given an 8-hour wait for an ambulance. We had another resident who sustained significant head trauma from an assault and was also given a 7-hour wait. Was also given a 7-hour wait on ambulance response times. And I think colleagues will recognise that both those timelines are outside of the normal agreed or standards that we try to achieve. So my question is, what are we trying to do to actually reduce those ambulance response times? And I'm going to be very parochial now and say specifically around Glastonbury. However, more widely for such a rural county as Somerset and the challenges therein. Thank you.
Thank you, Chris Turner, Assistant Director of Operations for Somerset. Thank you for the question, Councillor. And actually, I cut my teeth as a paramedic in Glastonbury, so it has a very soft place in my heart as well. Very, very good question, and it's equally complex in its answer. So the health system as a whole is far more complex than it ever was. The need of health is ever greater. So we have to look into innovative ways of managing our demands. Now, historically, we would have responded to most emergency calls, and we would have had the capacity to do that. And colleagues used to call it a waiting service. And obviously, we now know that's not the case. So what are we doing about it? So firstly, we want to maximise the amount of ambulances and resources we have on the road. And over the last few years, we've gone from 20-something thousand resources a week to 52,000 resources a week. So, and that has happened over the last 4 to 5 years. So as you can see, that is huge. We've had the post-pandemic challenges with ambulance days at hospital, and that's been well seen in the media. But we're working very closely with our partners with that because it's a whole system challenge. So that's the area that we're working on. We've got something called our timely handover process. So I'm really pleased to say that in Somerset, Musgrove and Yeovil lead the way in our region for the average handover time, which is fantastic. So straight away, that unlocks our opportunities for having ambulances available on the road. The next area is how do we stop an ambulance being dispatched to a patient where we have other methods that we can use to support that person in need on the telephone. So we do this through various areas. One is what's called our hear and treat. So a patient rings 999, call gets effectively triaged through our triage system called AMPDS. And then we have a process where it is deemed that this patient is safe to go through our telephone-based paramedics and nurses. They then use another system for triage to effectively manage that patient on the telephone, or alternatively managed through alternative care pathways within the community. And that is also done through something called a care coordination hub, which is what we work with the Somerset ICB. So then, of course, we have our spill of patients that require face-to-face assessment. And the area where we are working on is the response times for those patients. Category 1, life-saving, we've been talking about CFR and the importance of seconds. And 39 seconds doesn't sound much, but it's huge. It is absolutely huge. And as we saw at the beginning, waiting a minute sounds a long time and feels a long time when you're stood silent. Imagine you're sat with somebody in absolute need. So yes, there is more work to be done with category 2 responses in particular, because that's our most unwell patients beyond those who are in the category 1 response, strokes, heart attacks and so forth. So we have ambitious plans as an organisation to work to improve the category 2 response in that area. Hopefully that offers some reassurance to you.
Yeah, absolutely. So what I would ask is if it would be possible to see what those improvements are and offline, I'd be grateful.
I think actually that would be nice for us to have a briefing, perhaps a briefing note come in for us all. I think that'd be really good for us to know what, we hear the negatives, don't we? We don't hear the positives, so it'd be really good for us to do that, Okay, we have some returners. Don't normally allow this, but I'm going to. Councillor Hobbs.
Thank you very much. I have done the training, but I think it needs to be pointed out that the defib tries to be idiot proof when you open it, because it tells you what to do, and obviously it doesn't respond if it doesn't need it. Got the comments around that. I think defibrillators should have a towel with them so you can dry the body off when you're trying to resuscitate somebody. It's the unfortunate case I had, no towel in the box, and it was somebody who was in a pond. Secondly, probably the better since the men to cut the underclothing off women to get the pads to attach. In that, I mean, I had to work on a very ugly woman. I had to cut bare flesh. And I can imagine there'd be many, many men who are very worried about doing this, even in an emergency situation. And I just like a curveball in, not relation to defibs. Do you think it'd be a very good idea to install bleed kits, which are now being rolled out with every defibrillator, if possible? Thank you.
Thank you very much. So really questions there. So George is going to pick up the towels question in a moment. So firstly on bleeds kits. So these are something that are have started to hit the streets, not just in Somerset, but of course across the country, as we've seen more and more lives lost through particularly knives on the street and stab injuries, not exclusively, but largely that's what's driven it. And of course, that is desperately unfortunate as a trend. They are relatively complex in nature because they are inconsistent about what is a bleed kit. A defibrillator is a defibrillator. It does one thing, so it's utterly consistent. So we are working as an ambulance sector, so across the UK, to work out how best we can support bleed kits, how to ensure that we lean into where the evidence says that they add value, but it is something that we are actively working on and actively supporting. George, do you want to?
It's a really important question you raised regarding we call it a rescue ready kit. So something we strongly recommend is that every defibrillator has a rescue ready kit, which comprises of a pair of rescue shears to be able to cut through clothing. And importantly, you mentioned around bras. There is a national campaign for removing the bra to highlight the need to get defibrillator pads. Something we've been doing with our new community training volunteers is we've actually invested in female resuscitation mannequins to try and make sure that there is no health inequality in delivering resus training by going straight in and highlighting the fact that you do need to get the pads to bare skin, and that includes a towel and it's a microfiber cloth to make sure that there is no moisture on the skin and that you have no delays in being able to get those pads onto them.
That's really good.
Thanks, kind is brilliant response. Thanks, everyone.
Thank you very much. I think the training I did was on a dummy. And I think that's such a good thing. You don't realise this, do you, really, that you do need to, it can be someone else. As somebody that when I broke my leg, stayed 3.5 hours on the floor waiting for an ambulance, I can't tell you how thrilled I was when I saw you coming. But it was on a Saturday afternoon. You just don't want to break your leg on a Saturday afternoon in Bridgewater. It's not any good. So Okay, so now Lucy, councillor Trimble.
And thank you. So I was going to come back anyway, because obviously I was mentioned. At no point was I saying we shouldn't have defibrillators if they get vandalised. But we are facing a situation, you know, where I live, it's a very nice place, but unfortunately the building is now an abandoned building that it's been attached to, still with an active sports pitch opposite, which is why we need it. But obviously it's a draw for vandals. People come on visit the area just to vandalise this building, it would seem, and part of that was the defibrillator. So now this parish council, who have limited funds, have got to make a decision to buy a new one and find a new location, and we don't have any other public buildings in the village. So, you know, they're left with a tricky situation, and that's the problem, is just how do we, you know, if there's anything that can be done, or if anyone's working on innovations to try and make them less vandalizable. You know, in supermarket checkouts, you look up, don't you, and you see your face on those self-checkouts, you think, oh, good God, you know. But if you had a CCTV or some sort of monitoring thing that came on when somebody approached it, that might be enough to put people off innovation. Add to the price, I get that, but I think I would probably rather pay a couple of £100 more for the security of knowing it's not going to be trashed, and then we could have it put back up in that place and feel confident it was there for local people.
Thank you, Councillor. Two very good questions. So firstly around innovation. So we're proud to say that as a service, we've worked with the councils in Gloucestershire to install the first lamppost defibrillators, removing the need for them to be installed directly onto buildings. And it's something that it's been taken through the MPs recently to look at can new developments in housing estates have these, because they can be installed. Lampposts have electrical supplies already, and it means it's an easy solution to install them in the real areas of need rather than direct to a building. The other element, I think actually links into around engagement training. You look at the vandalisation that happens without judging people, it tends to be school children not knowing what it is. So actually by us supporting our volunteers going in to train not just all communities but including schools, just raising awareness that it's a life-saving bit of equipment, it could save their family, their loved ones, I think will reduce the risk of them becoming vandalised through awareness of what it is and the importance of it.
Okay, thank you.
Okay, now I think councillor Sully.
Very, very quick. I just want to thank Councillor Hobbs for bringing this to the agenda. I think it was it. Sorry, am I wrong saying it was one of your first committee things you wanted to bring to? But
yeah, it was. I've finally done something which I think is very important.
No, and I think it's important as committee members that we bring the concerns of the communities and our experience. And I just wanted to echo about the training and whether, Edric, we can take this forward to get training to councillors, as our chair has mentioned, and whether that can be another thing that you help inspire. So I just wanted to say thank you, Edric, and let's be positive and do some training for councillors after this, so we can have a conversation. Thank you.
So we would be delighted to work with you in providing training and showing that CPR is a skill that we can all have and we can all use, and that it would make a real difference in creating a county of lifesavers. Thank you.
Yes, I think we all agree we'd like to be able to do that. As I said earlier, I'd like to do it, but I do want the uniform as well, if that's okay. Councillor Wales.
Just to reiterate what was said earlier, but might help Lucy, is the fact that it appears, am I right in saying, that the unlocked cabinets aren't vandalised nearly as much as the locked ones. So the answer is, give the locked cabinets and get an unlocked one. And then it seems to be our experience anyway around Chard. We have very, very, very little vandalism to the unlocked cabinets at all.
Yeah, and I think you said that earlier, which is good, very good point, but good reminder. Thank you very much. Okay, now the people online have been very, very patient, so I don't want them to fall asleep. I'm sure they won't. Can I go to Councillor Tom Power, please?
Thank you, Chair, and I'm really sorry I couldn't be in the room today. I think it's like two questions. It might be two questions now I've written it out. So apart from being a councillor, I also work as a duty manager as a leisure centre in Wincanton, and I've seen firsthand what a DFib can do, because I had to deal with an incident of a cardiac arrest in the middle of the pool. And this was at 7:10 in the morning, so it was quite a wake-up call. But unfortunately, the casualty didn't make it, unfortunately. And we had, by the time we got the DFib pads on, you guys were there because we had to dry them off, put the DFib pads on. But after the incident, we had to borrow the school's DFib, due to the fact that obviously the pads had to be changed. So I wanted to know what the average cost for changing pads and batteries are. And before I finish, I'd just like to say that I think what Councillor Sully and Councillor Hobbs have just said about training for counsellors, well, if I was the education secretary, I'd make sure that every child had DFib training before they left school. So, you know, everyone in the whole country knew how to use DFib. Thank you.
So I'll ask George to comment on the cost. If I might just pick up first of all on the reflection about ensuring that all young people have the skills. Of course, the answer to both the provision of AEDs and people having the right skills is largely a policy one where we can, and we've seen across the UK changes of late, like introducing these skills into the driving test. We know where we can make big shifts like that. We can really begin to change the dial on out of hospital cardiac arrest survival rates and move us from where we are now, which is not a world leader, to where we think we should be, which is that people in the UK should have the best possible chance of surviving an out of hospital cardiac arrest, because the interventions are low cost and low skill. And those are the things that make the difference, and all the evidence points us that.
Thank you very much. I do think, what I wanted to ask you before I go to the last speaker is that you said that you could come in and do training for counsellors, and I think this group has made it very clear we'd like that. We need to know how you would do that, if you would do it on a separate day, or if we could do that on a situation where your time is available. But I do think for us it would be really good if we're advocating how important this is, then we need to know much more about it. I've done it many years ago, and I was thrilled that I could do it then. But I've always worried. People worry that they get it wrong. And what they say is anything you do is better than nothing. But I think it is so good. So I think we need to liaison perhaps with Helen afterwards, if that's all right. We'll work out somewhere when it's good for you. We can have a separate day. But I think bring in your lady and gentleman dummies. Are they allowed to be called that? I don't know. Or people. And I think we could write. I think we're serious about this. We really want to know. But the one thing that I noticed on the report, there is nothing about costs. There is nothing about a DFib. We want to buy one, as I said before, but I want to know the right one. I carry a battery where I live for the one that's down in the shop. And what I'm saying is, we need to know where to go. There are so many out there, and it's really a minefield. And I think we need some guidance. And I think some guidance information would be really great.
Thank you, Chair. And I completely agree. There's lots of models out there. It could be quite a confusing world when you're looking at buying a new DFib. So as an organisation, we don't sort of sell DFibs or sort of consumables. However, we do signpost towards which ones we would recommend through ones that we have used. There was a previous question around the average cost. I would say it's very difficult to actually put a cost on it because each supplier and supply chain charges slightly differently. But most pads are under £100 and batteries can be slightly more, but it very much depends on the model and whether they are a combined set or not. And in regards to your training, Somerset have just taken on 10 brand new community training volunteers. We would love to come and run multiple sessions for you and the committee. And I would absolutely love to showcase the new equipment we've brought. We would be delighted to do it, and we'll be in contact and sort some dates out.
That's really good news, and thank you for that, because the positive about this is that we need to be educated as well, know that we can go forward. I also want to know about your the fact that your funding. We also need to know how you're managing your funding. You've told us a little brief about it today, but we need to know how that works. Is there a model for your charity that you can actually go out there and find what is it? Is there grants you need? you haven't stated that, what you could do with, you've been really good, you could have done. And I think we'd like to know a little bit more about that, is how you get your funding, what you need, do you need grants? Is there something that will actually help you to be even more efficient than what you are? So I think we need to make sure that we move forward in a positive way with this and we get some really good answers. Is that okay? So, okay, all right, I'm going to go now to Councillor Graham Oakes, who's the lead member. Councillor Oakes.
Thank you very much. It's been very interesting, and thank you, gentlemen, for coming from the ambulance service to talk about this very important issue. Over the last 3 years, Yeovil Town Council, which I'm a member of, has embraced the need for defibs, and we've gone from having 1 to having 19 across the town. They also now have bleed kits. I'll get used to the new terminology in time, but we'll call them bleed kits at the moment. All of them are locked, and I'll come to that in a second. I'm very excited by the concept of being able to use lampposts, because we have had, strangely, even the co-op, we had the co-op turn us down to put a defib on the outside of their building. So we do have some landlords refusing to work with us, although we've had a lot of people helping, and it's not just been the town council. We've been very lucky, a number of organisations working with us. The one thing I would say, there are 2 issues that I have. One is, I will point out that 18 months ago, roughly, I had a heart attack. I'm at work now, and it was in this building. It was on the way to this building that I had a heart attack, and the ambulance took over an hour to get there. Now, my view is that there are always ways you can improve your service, but the fundamental thing is you do not have enough ambulances and paramedics. You don't have enough. And I think we need to accept that, and the government needs to change it. I could hit you with a big stick, but it isn't actually going to help, because the amount of vehicles you have on the road compared to the need just doesn't match. And we need faster response times. We need better throughput through the hospitals. There's a whole lot of things we need, but I would like us to be able to support you guys in getting the kit and the staff you need to deliver the service that the public think they're going to get and think that they're paying for, which they're not really getting. The other thing is Yeovil went for locked because of our pessimism about whether they'd be vandalised. And I can tell you that I'm going to be recommending to the town council we go for putting codes on all the boxes so people can undo them. The calling system, when you phone the 999, does not work to get a code. We had a case where we had, in fact, one of my staff ran next door to the defib, and the call took over 8 minutes to get a code. And, you know, the expectation is you start no longer than 5 minutes. Luckily, in that case, it actually didn't cost the life of that person. But the system at the end of it doesn't work, or it doesn't consistently work. And with something like getting people codes, has to be 100% of the time. So that's why I've switched my view on it now. I'm going to be recommending we put the codes on all the boxes, simply because your system doesn't work. We thought it would work well, but it didn't. We made an assumption. That was a mistake. So we will be looking at it. Because I'm really pleased you came today, because it will, I hope, if I can persuade the rest of the town council, make a real difference to the people of Yeovil, the way we operate. And like I said, I'm particularly excited about being able to use lampposts, because we've got them everywhere. So we really can hit our 500-metre target, which is what we're operating to. So everyone can do it, the travel time, okay. Sorry if that's a bit critical, but better to be open and honest.
As you always are, Councillor Oakes, we appreciate it. Thank you. I would like to sort of thank you very much, gentlemen, for coming today. I think, as you can see, we're really interested. This is an action committee, and I think what we do need, our actions today are ensuring that we can get some training for this committee first. We'll put some actions in place and if you can speak to Helen, to our Angela, that, you know, so that we can set some dates in place that you can come and give us actions. What we need to know is also about your costs that are needed, your charity status. We need to know what you need. We need to know where we can help you, where we can make it better if it's possible. And there's always possibilities that if we don't know from you, we would really appreciate you coming. So we really want you to come back. And I hope that we'll hear from you perhaps within the next month when you can give us a date and time. But I think we'd like to have you back as a committee to, you know, where we can give you feedback. I think you need to know how well we've done with our training as well. So, but I really thank you very, very much today. And I also thank you for the work you do. It's some tremendous, tremendous work. And we are full of admiration for you, honestly, really are. And keep up the excellent work. And I still would like a uniform size small, please. Okay. But thank you very, very much. Thank you.
Thank you for having us.
Oh, pleasure. Pleasure.
Thank you. Thanks, Sharon.
Right, I'm going to now we're going to go to item 8 before we go to item 7. I'm going to give just a 10-minute water break, if I may, please. Just a very small break. Is that okay? Thank you. Okay, then I'm just checking everybody at home. Can you hear me, please? Everybody online, can you hear me?
Loud and clear.
Wonderful, thank you very much. Okay, committee, we're now going to item 8. We're just reversing this. And this is the redesign of the NHS Community Hospital Services in Somerset. This is pages 53 to 64. And I like that title. That's much, much better. And I'd like to invite Alison Rousewell, Director of Localities and Strategic Commissioning, to introduce her report and to present with everyone else, if that's okay. Alison, yes, sorry, Alison, I lost you then, Alison, sorry.
Thank you, Chair.
And we do have also, I just want to make sure, just to let people know at home, we also have Kate Smith, the Associate Director of Strategic Programme, NHS Somerset, Abby Fernell, Service Group Director, Neighbourhoods and Community Services, Somerset Foundation Trust, and Kathy Doran, Deputy Service Group Director, Neighbourhoods and Community Services, Somerset Foundation. Just want to say to you, we really do appreciate you being here today. You're very, very busy people, and I don't know how they're going to manage that you're here, but I thank you very, very much. So if you'd like to, Alison, thank you.
Thank you. And thank you for having us back to talk to you about reimagining our community hospital services. Yeah, you will recall that we came to the committee back in August about the proposed tests and learns that we were undertaking, as well as proposed plans for other community hospitals. Today, we want to provide you with an update on the evaluation of the test and learn at Frome, West Mendip and Bridgewater community hospitals, and to talk about the development of a new test and learn in Crookham and Burnham community hospitals. The test and learn supports the 10-year health plan and how we move care from hospitals to communities. We want to retain the essence of our community hospitals and to care for people locally and modernise the way we do this that is fit for purpose. This is about using community resources, including community hospitals, in a way to allow the best possible local delivery of care. We are requesting that members support the plans to extend the test and learn in Frome, West Mendip and Bridgewater community hospitals for a 12-month test period, and the test and learns in Burnham and Crookham community hospitals. I'm now going to ask my colleagues to provide a brief update on the test and learns, and then we will provide responses to any questions that members may have. Kate, can I hand over to you?
Thanks, Alison. Hello, everyone. So we the first thing we did was redesign our intermediate care services in Somerset. And you've got a little bit in your papers about intermediate care services. These services support people after hospital stay, if their needs have changed, if they're not as independent as they usually are. And the test and change had 3 kind of components, really. One was increasing the amount of reablement support that we provide in people's own homes, because we know that people recover best in their own home, surrounded by their own environment and with people that love them. We also had a group of people that were accessing our hospital services and then afterwards needing a long-term care home. Maybe something catastrophic had happened. And this group of people didn't have a good good offer for this group of people. And instead of moving from hospital into their long-term care home, they would need to travel through our community beds, such as our community hospitals. And then some weeks later, they would eventually move again to their long-term care home. So we wanted to take out that additional step. And so what we did as part of the test and learn is we created some beds, some care home beds that people could access directly from hospital. And then if they need that level of care, they could take the option to stay there long term. And if we kind of worked on the notion that actually if more people are able to transfer directly home from hospital with the right support, and the other group of people were able to access care homes directly from hospital, then perhaps we might not need to be quite so reliant on our community hospital inpatient beds. And so that's where the kind of notion came about. Let's temporarily trial operating on a kind of a reduced community hospital bed base. And actually, perhaps if that was successful, that might open up some opportunities to use those spaces differently and make our community hospitals more vibrant and maybe deliver services in those spaces that perhaps people are travelling long distances for. But obviously, big changes and very much needed to be a test. So timings and sequencings was really, really important. So in the paper, the findings measure the outcomes from the end of September to the end of December, which is a sort of 12-week and 3-month period. It's worth noting that we started to increase the amount of reablement support in people's own homes earlier on in the year. It was around the sort of summertime, sort of June, July. And then we brought on the new care home beds and reduced the community hospitals gradually as people were discharged. And that's why we chose September as the start date, because we knew that all 3 of those changes would be operational. And so I just wanted to mention about the timings. So kind of what did we find? Well, for those returning home and having their reablement at home, we found that we were able to support more people on that service, which was great. Our waiting times also reduced, which was great. We'd invested more hours, so more people accessing the service and waiting times reduced. If we reeled back to March last year, people were waiting on average 6.5 days to access that service. And in the test and learn paper, you'll notice that we reduced that to just over 3 days. So fantastic, but still too long. And our ambition, which we hold firm to, is that people shouldn't have to wait any more for that support at home for any more than 2 days. So we've got some more work to do, which is why we want to carry on testing and refining and improving the model that we've embarked on. The supply of the care home beds, they've worked well. That group of people now don't have to travel twice through different beds. They can access a care home close to where they live. They've got more element of choice around that, which is good. And the large proportion of people using those beds staying there long term. So I think it's just over 91% of people moving from hospital into one of those care home beds is staying there. We've had a couple of people go home and a couple of people choose a different home, but by and large, working out as intended. It's taking a little bit longer to access those beds than we'd like. We don't want to rush people too much with this choice because it is a long-term decision and we want to give people and their families time to view care homes. We set an ambition that people be able to access these beds in about 5 days. And it's higher than that in the test and learn. It was around about 12 days. But that's fine. It's a brand new model. We know where we need to improve. Again, the reason why we want to continue to test and learn is so that we can reach that kind of 5-day target. And then the temporary closure of community hospitals that occurred in Crewe Hospital, West Mendip, and a few at Bridgewater Hospital. And again, we were working on the sort of notion that actually, if we've got more people going home and some people are able to access care home beds, then perhaps people wouldn't need to wait quite so long for community hospital beds. If people are in the right bed, they might not need to stay there as long and our length of stay might come down. And during the test and learn, you know, we absolutely found that waiting lists came down. It didn't matter whether you're waiting for a community hospital in RUH, Western, Musgrave or Yeovil, the waiting times came down. The length of stay in the sites where we've reduced the beds fell, which was good. And so did the number of delays. So people didn't get caught up, stuck in those beds waiting for something else. So everything was flowing better, which was great. But I think what was really great to hear was the feedback. We really wanted to hear from people during this test phase. We reached out and obtained the feedback from service users, so patients themselves, as well as carers. Carers were a big group of people that we wanted to listen to carefully. We were cautious that actually if people were having their reablement at home, would there be an impact on carers? We're really pleased to be able to report that overwhelmingly the feedback from carers and patients was that they preferred having their recovery at home. Home was the better setting for them to recover for a whole host of reasons. In fact, everyone apart from one carer said home was the best setting, and they hadn't and didn't want to have stayed in an inpatient type setting any longer. Any kind of reports of negativity were really isolated. Where those sort of that feedback came through was around care visits and scheduling. Quite often when you're having care visits or reablement visits, and in this instance at home, you might be given a 2-hour window. If you're receiving 3 or 4 calls a day, that's 3 or 4 2-hour windows, and that can be a little bit of waiting around. So that's useful feedback for us actually. We can have a think about that. So that's the sort of high level position on the findings, which are in more detail in your packs. Before I sort of allow other colleagues to speak, it's just worth really a caveat about what's happened since Christmas. And our health and care system is under a lot of pressure at the moment. So the changes that we made last year that we've continued with are under a lot of pressure, and they're really being stress tested. And that's part of the rationale really as to why we want to extend the 12-week test and learn up to 12 months, because we really want to make sure that the changes that we're making are tested under all sorts of different scenarios at different points in the year before we land on any kind of permanent decisions about how we operate intermediate care services in the future. So things are a bit more challenged at the moment, but I'm really pleased that we're doing everything in a temporary fashion so that we can make modifications and refine what we're doing in response to those pressures. So before we take questions, I'm just going to hand over to some colleagues to talk about the work that's posed at Crewkerne and Burnham Hospital. I'll hand over to Abby or Kathy.
I'll hand over to me. We are seeking support from the committee to consider some temporary bed reductions in Burnham-on-Sea Community Hospital, which is currently at 16 beds, and Crewkerne Community Hospital, which is also currently at 16 beds. We have done in the last 4 to 6 months a huge amount of engagement with our community colleagues, with our leagues of friends in both of those areas, to look at what that provision could be as a community provision for both Burnham-on-Sea and Crewkerne Hospital. And from that, what we have ascertained and got from our feedback is that both of those hospitals would be supported in going to an 8-bedded model, so not a no-bedded model, but an 8-bedded model with additional provision going in there to support the community. We've looked at population health needs in both those areas and what the population are going out to our various acute hospitals for, and are designing as we speak what we think those community hospitals could have and be supported in delivering from those locations. So those are ranging from chemotherapy support to ambulatory care support, which is currently, for Crewkerne in particularly, currently hosted at Yeovil District Hospital and can be well supported from Crewkerne. Crewkerne has, by the side of it, a GP practice virtually adjoined to there, and we're looking at collaborating with them around what we might be doing around same day urgent care and primary care activities that we could do together jointly. For Burnham-on-Sea, very similar. We are looking at what provision we can have there from an outpatient's point of view. It's already a very busy unit, particularly Burnham-on-Sea. We're looking at what we can provide there that is already maybe being provided at Bridgewater, but can be done in conjunction with Burnham-on-Sea as well. And again, looking at things like chemotherapy, particularly, and investigations going up there. But again, we've got a GP surgery across the road there, which we're looking at collaborating with and doing some same day urgent care together there. So in summary, we're designing that at the moment. We're looking to see if we can seek approval to go and start a process from about the 1st of April, and then we'll begin to build up those services from that point on. But the plethora of services, as I said, is just being designed as we speak. And we'll be able to give you further information about that.
Thank you. Thank you very much. Does anybody else want to add anything? I have to say, can I thank you very, very much? Everybody's got a lived experience. We all have. One wonderful person I know has just died. She was given 2 weeks in Beacon Centre and has lived for 20 weeks. And that is amazing. And although the last few weeks were very, very bad, I actually learned from her how important it is to be at home. And I think this is good. This is not just a cost-cutting exercise. This is about care. But I think the words you've used, and one thing I did say to Andy Heron, don't say reducing beds. You know, redesign is perfect. As soon as you mention the word reducing, everybody goes in a panic. Oh my God, there's no beds in Burnham, there's no beds in Crookhern, and people get panicky. The one thing I would say is about Bridgewater is that you've been able to bring diagnostics into Bridgewater that normally would have been sent to Musgrove. And I think that is so important. So important that you've got not half of Somerset dashing to Yeovil or Musgrove, that actually these community hospitals can be used to the extent they need to be used. And I think this is as a wonderful way, and the test and learn will bring out more, of course it will. But I can actually, I advocate on lots and lots of people that I live in perhaps more elderly, and hence me, and you do learn from other people and what they say, and it's very, very important that we do take on board what people are saying. Doesn't work for everyone, we understand that, but I think to be able to utilise our community hospitals as they should be used, I think that's really, really good. So I will come back, but I just want to put over now to Sarah Wakefield, who's our lead member first, and then I've got some other people to speak.
Yes, thank you. Thank you very much. I am the lead member for Adult Services, Housing and Homelessness. I just wanted to say a few words. First of all, thank you for coming. Great to hear how it's all going. You didn't really say, perhaps in your report, we didn't say how much we're doing hand in glove with Adult Services. We were already doing reablement, as you probably know. We are hand in glove with you over intermediate care, always. We have to be. And we do try and get people out into care homes as quickly as possible if that's where they need to go. So I think the situation, I just wanted members and people listening to understand, the community hospitals can be, for some people, a staging post, or have been a staging post. For some people, that's the wrong thing to do, to put them from one bed into another bed, when actually they'd be better off getting up and about and having some reablement and all the rest of it. And we know that. So that means that if we don't use them as much, because we're getting people home quicker, then you may not need the same bed capacity. And my understanding is that there is some vacancy in the bed capacities across Somerset, which has perhaps given rise to what you're now planning. So I just wanted to say, just make it absolutely clear that this is a joint enterprise with adults, and we're working together over this. And intermediate care, that really difficult area of getting people out of hospital into the best place, wherever that happens to be, is one that we're all working hand in glove all the time to make better. And I'm delighted to hear the progress that you've made there. Thank you.
Thank you. Thank you very much, Sarah. Thank you. Councillor Wakefield. Councillor, I even go to Councillor Sully.
Thank you, Chair. I want to reiterate, thank you for coming in and being open and collaborative with us, which is better than the first time around. So some learning has done there. But I have some questions. Because I don't feel the report goes far enough to reassure me about the robust analysis. I'm looking for more. I've got questions really. Before more beds or redesigned or cut 50% those two hospitals. And that will make me struggle to support a vote, to support you with those, with what you wish to do, your second step, but that's me, I'm talking for me. Right, so I'll be really concise, and if you can respond to as many as you can, but if you feel you need more time, I totally understand. The vision is bringing residents home. So, but that's included, but redesigning beds, I'm being polite to chair, or removing beds. So a resident, I know spent their significant birthday, 90 something, in Burnham War Memorial Hospital, recuperating after a fall since Christmas. The issue is she lives in the Mendip area. And I thought it was quite sad that, you know, that local people of her age and generation would struggle to go and wish her happy birthday. So first question, is there data that shows where people are going when they are in hospital? What has the impact been on hospitals, Musgrove, RUH? Are there delays in discharge? So this is very much a report about your part of it, but what about the knock-on effect? I'd like to see some data on that. And I know that you have Anna Sabine was asking detailed questions around that, the impacts, the modelling you did, and the risks, which obviously you're going to come back to her on that. You've got 100% success rate, which is really, really great. Satisfaction figures, 100%. But I can't see what your selection was, how many people responded, and how you collected those 100%. Is it you saying, are you happy you're at home? So I feel like that gave a sort of slanted view on everything. And the commissioning of care homes, I did pick up on what Sarah has already mentioned. You're moving to a spot purchase model, which the Somerset Council is leading on. When that's in the report. So when can we get an update on what it looks like for the Somerset Council side of it? Where's the data? I don't think this can stand alone if we're totally evaluating it, because you're showing a sort of slice of your part of it. And sorry, Sarah, okay, sorry. I thought you were talking to me. Can you provide mortality data for the test period, comparable baseline period, broken down by re-enablement at home versus bed-based care, and with sample size, statistical significance, and any review and learning from that? I just need more details really before I could fully support your ongoing progress with this. But I do appreciate that the sentiment and the vision of caring for people in the best possible way in their homes, but I'm just not seeing how, if you're delivering and mitigating risks. Thank you very much.
Thank you. Answer to those questions, I think I can answer some of them. The mortality data we've absolutely got. I just need to go away and provide that afterwards. The feedback was captured in two ways. Every person who receives their reablement at home has access to a QR code. The uptake on that normally isn't brilliant. So during the test and learn, we actually made phone calls, open-ended questions, what went well, what didn't go well. And then we were very brave, and we asked them whether they would have preferred to have their reablement in a community bed or at home. And putting those two feedback mechanisms together, that accounted for 5% of people using the service. So that gives you a bit of an idea in terms of, you know, the strength of the voice. We obviously want to increase that. We want to capture more voices, and so that would be our plan really going forwards. The pathway 3 outcomes, I think, Emily, we could provide some information afterwards in terms of impact on the council. We've obviously focused on impact on the person, but that data's there, that's easily retrievable. We could take that as an action. And I think you're right, it's really nice to see the outcomes through the lens of the council. So that's great. And then in terms of kind of who's using our community hospitals and where do they normally live, we've got some data that shows admissions to community hospitals broken down by their primary care network. So we've got some data before and the year leading up to the test and learn, and then the year leading up to the end. It's a little bit difficult because sometimes people accessing a community hospital outside of their primary care network sometimes works better for people because their daughter lives over there. And so I think sometimes we just have to be mindful of that data, that there is an element of choice and sort of behaviour that actually it's important to look at the admissions by PCN, but we have to play in that kind of nuance that actually sometimes someone might live in Langport, as an example, but might not use the bed. They might go slightly further afield for that sort of thing. But ultimately, our aim is absolutely for people to use the community hospital that's either most local to them or makes most sense for them. But yeah, we've got some early insights into that data, again, which we could summarise and share. Also, if there's more information that you want, let me know. We've got an enormous amount of information behind the test and learn, and it was difficult to get the balance in terms of overloading you guys with information and keeping the report kind of digestible, I suppose. So yeah, we're absolutely happy to share more information, and we love curiosity.
Well, you're going to be happy here. I can honestly tell you that the appendices that you put in as well, I thought was very helpful, which showing the pathway 1 and everything. And I think that if you spend a bit of time looking on that, it does answer a lot of those questions. I think that was very, very helpful. So I thank you for that. But of course, what we will do, as you know, we always have a return visit. So what we'll want to know is in sort of whenever you think 3 months or 6 months, you want to come back in and bring us statistics that you've got up to date. That is what we really want to do. We want to follow this up, okay? So, but thank you for that. Can I go, I've got up online, but Councillor Trimnell.
So I've got a couple of questions on page 55 of the extent. There was, am I on the wrong page? Yeah. Sorry, it's been a hell of a week. So there was something about readmission rates, and it said that it had risen by a very small amount. But actually, when you look at a rise of a 2% percentage point rise from September to December, I was assuming that that could actually be down to seasonal factors as well, such as just flu and things like that. So I wondered if you because I would have thought if it was down to that, you might have said this could be explained by, because obviously there's a lot of concern over this, and people will be looking for signs of it working or not. So I just wondered why that wasn't explained. And then it said that the number of bed days lost because of delays is reduced. And does this refer to the through movement in hospitals where fewer patients deemed fit for discharge or with no criteria to reside? Is that what you're talking about there, where we have these problems with no bed spaces being made available? So are you saying that that is being freed up and that the flow into and out of the hospital has improved? And so hospitals are feeling the benefit of this. And then finally, I just wondered, in terms of expansion of further services, I know I have a friend who's having dialysis, has been having to travel up to Bristol every day to a hospital there to receive it, but could be going to one of these more local hospitals where they've got easier parking. I mean, I think they have to be there at 7 a.m. So it's so early, and it's just that in itself actually is, I think, more harmful to a younger person than for an elderly person to be discharged back into their home with the support in their home. So, I generally support this idea. I certainly support it being investigated further, but I just wondered if you could sort of explain what the future looks like on just those details on the report, please.
So on the readmissions, readmission rates back into hospital, they change by a percentage or two each month. So like 13, 15, 14, 16. It is common to see a month by month, just up, down, up, down, up, down. So a level of variation. And during the test and learn, we didn't see any changes in that normal level of variation.
Right.
So that kind of clarifies that. During the test and learn, what we saw was the number of people delayed in hospital falling and the duration of time in which they're delayed falling. And that's where we got that's how we knew we'd saved some bed days. Obviously, just a little bit of a caveat that everyone's under pressure and the system is under pressure at the moment, which is why we need to continue to test to be certain we've got the right model. But yeah, that's what we saw during the test and learn. So that's the readmissions and the bed days. Dialysis.
So, yeah, I know that must just be having to go however many times a week for that. That is quite a schlep. So we do offer. So Bristol offer out of room community hospital dialysis support. We can certainly go away and make some inquiries, but that is something that is likely to need to come from one of the kind of hub NHS organisations, which is not Somerset Foundation Trust. That is likely to need to come from Bristol. But yeah, really happy to just make some tentative inquiries on that. But I just want to manage your expectations and our ability to be able to influence the guys from Bristol to be able to set that up.
Yeah, I just think the whole benefit of this is that we can bring services, distant services, close to people. So I'd love to think that the future path for this will be that those services that, like you say, you know, several days a week and such a long time, if they can be brought closer to home for people, you know, that would be amazing. Other things such as chemotherapy, things like that, where at the moment it's a big deal. I mean, these treatments are a big deal for people, but it's an enormous deal when you've also got to travel so far for so long. The parking is often more difficult or more complicated. You can't be dropped off and left there for the day because it's not worth the petrol, you know. So it's all of those complications. So I'd love to hear that the future will be and really increase in those services being offered. So thank you.
Yeah, so chemotherapy, you know, we have a thriving oncology service from the Beacon Centre and from St Margaret's at Yeovil. So that is certainly something that we're pursuing with the team to be able to look at. Burnham-on-Sea will probably be able to come online a bit more quickly, but we'll think about what we can do later in the year at Crewe Cairn as well. Had that conversation with oncology this week.
Thank you.
And that's a very, very good point, Councillor Trimmer. And we want it in Bridgewater as well. We're ever rising in Bridgewater.
We've got Bridgewater, yeah. So we have a chemotherapy, or do you mean dialysis?
Well, chemotherapy, but it is at Bridgewater.
Yes, it is, yeah. So we
yeah.
currently run chemotherapy treatments at Wellington, Willerton and Bridgewater.
I mean, this is just so excellent, isn't it? That's just amazing. Long way from Mendip, but life's not perfect, is it? So, you know, okay. Thank you. Councillor Wales.
Yes, thank you very much. Although the main thruster today is the test and learn extension, as I read it full, I do note that down in future provisions in the here mentioned the Shepton, Mallet, Chard, Wellington Community Hospitals, and I'd just like to sort of say a bit about the Chard Community Hospital, which many years ago, been doing this too long probably, it had two wards. Chard Community Hospital had two wards, and frankly, during that time, all we did, I suspect, was move the bed blocking from the Musgrove to Chard. So that they were in there for weeks and weeks and weeks. So anything to stop that in these other hospitals is obviously what we're trying to achieve here with the movement straight to home. And on the Chard Hospital itself as a community hospital, it is now providing any number of services which we have to go to the main hospital for, like blood tests, simple thing like that. How do you get a blood test from your local doctor? You get an appointment. We all know it's like. Now you can go to the community hospital, get your hospital blood test straight away. They're doing maternity services, I believe, there now. Obviously, there's the minor unit injury unit, which is always busy. So Child Community Hospital has morphed from being this 2-bed, rather ancient establishment actually, to a really modern use of facilities, and it's for all ranges of people as well, all age groups, which I think is tremendous because, as I say, we've got the cancer nurse comes out. I know to my pleasure with hardly, but it saves them to go all the way to Musgrove, I tell you. And so X-rays, it really is now for the whole community, and it's just as long as we can deal with the people, mainly elderly, who need to go from hospital to care by sending them home, I think it is tremendous. We should support it as well as we can through the council services, as Sarah explained over there, and the services of the NHS. Thank you.
Thank you. That's, I don't think you need to respond. I think that's
No.
an endorsement, and I think that's very well received. Can I go to Councillor Cameron, please?
Thank you. I wouldn't find it hard to accept this in its current state. And I'll give you the perspective of people in Glastonbury. Our local MP talked about Glastonbury being an NHS desert, specifically around dental services. We see West Mendip Hospital dropping from 30 beds to 16 beds. That's a 47% decrease. And of course, none of this happens in isolation. We've seen 3 of our pharmacies drop to 1 over the last few years. We've seen a 40% increase in reported crime over the period January to December 2025. We've got in excess of 250 people in the caravan community and hard to reach community. We've seen homelessness increase by 50% over the last 5 years in Glastonbury. And then mental health need has gone through the roof. So what I would really be keen to understand in the wider strategic context is how do we plan to develop our community hospital service? And what I'm thinking is, where is the definition of the community wellbeing hub? The people in Glastonbury would like to see health services developed in the community around that community wellbeing hub concept, i.e. women's hubs, elective hubs, community diagnostic centres. I mean, it's fantastic we've got a community diagnostic centre up here, but for Glastonbury, it's still an hour away. And you can't get here directly. We haven't got a train station. We haven't got direct bus services. And if you don't have a car, of which many of those in need don't, then how do you get to these services? And then I've already talked about mental health services and dental services. So I'd be really reticent to support this without an understanding of how this nests in that wider, higher strategy. And I think, yes, what I'm saying here is, can you please reassure me that this is going to then lead on to the development of a community wellbeing hub in Glastonbury?
I just start by saying, and I'll hand over to my colleagues, part of the test and learn that we're doing are also looking at establishing neighbourhood stakeholder reference groups. And certainly there will be one in that area, which Somerset Foundation Trust colleagues will be leading on. And it's about looking at all of those services in the round. So we talked about the 10-year health plan and the move to, towards sort of neighbourhood health centres. And really that's the whole purpose of having these neighbourhood stakeholder reference groups, to be able to work with the local population, with local stakeholder groups, to be able to, reimagine what that could look like in the future. So I don't know whether Annie, you want to add anything?
Yeah, thank you for sharing it, and the way in which you put into context kind of your views is actually really helpful for how it feels for the local people in Glastonbury. And I think it's really important. So we are in discussions. Obviously, St Dunstan's is the new sort of community hub project, which, if it hasn't yet opened, is opening pretty soon from memory. No,
Last year.
Yeah, it's opened last year, November. So we're in conversations about how we can work together to try and make use of some of that space. And yes, within West Mendip Hospital, we do have some space at the moment that we need to work with the stakeholder reference group to look at how we can bring services in. And I just think the statement that you've made today has been a very helpful focuser for this project, and we'll take that on board. Thank you.
Yeah, certainly, yeah.
I volunteered to be part of the stakeholder reference group, so I'm already feeding into West London Hospital. The point being, however, is that, we've got a UTC, as you're probably aware, there. And for treatments that are available at that location. Because of the way we've designed the service and the support services around that services, often it necessitates where injuries could have been treated within the UTC context. They're still having to go to Yeovil because bloods are out of hours and all the other bits and pieces. And you and I both know that the delivery of lab-based services is irrelevant on the location, just as long as you've got the logistics in place to support it, of which the UTC currently doesn't. So that concept of radically changing the way that we do business and how we actually deliver the services into the community as part of that 5-year plan, the 3 shifts and also the 5 big ideas, absolutely on board for it. It would be really helpful if we could understand that strategic level context of how ambitious but how ambitious we plan our community hospitals to be in the future.
Okay, can I, thank you. Can I move on now to Councillor Bruce, please?
Thank you, Chair. Thank you all for the presentation. It's all really very interesting. Got a few points to make. They all kind of fall under the umbrella of the equality impacts, really. So we started off with a 12-week test and learn. Proposing to go on for 12 months. Is that right? 12 weeks is a temporary thing, easy to turn back on. 12 months, I'm a little bit. I'd like some reassurance in terms of if you're doing this test and learn for 12 months, how easy is it going to be to turn back the clock at the end of the 12 months? Because you've got services that are going in there that people get used to using. How easy is it going to be to take those away if the equality impacts are actually too big to ignore and we can't mitigate against them? So the 3 points that I picked up on really on the equality impacts is that it's the criteria that you've used for scoring the age and disability impacts, because they've been scored as moderate. But the narrative actually picks up that older people, 65 plus, are going to be most affected, and the disabled. So I'd like to understand a bit more about the criteria that's been used for scoring it as moderate rather than high. And also why even the moderate impact would not sort of trigger a full equality impact assessment. There's a note on there that it's not needed because it's not a high impact. So, and then the other point is I'd like a little bit more explanation in terms of destabilising the local care market. There's a note in the impact assessment about that. So I'd like to understand a bit more about what that means. Is it about local care home capacity? Are there any contingencies in place if closures occur? I'd just like to understand a bit more because it's not really very clear for me. And then the other point that I wanted to make is the rurality aspect. Rurality in Somerset obviously makes transport and access more challenging, impacts patients, carers and non-car drivers. So how are you monitoring the impacts of travel and rurality on this programme as you go ahead, and what contingency plans are in place, or you think?
Yeah, I'll pick up the scoring around the age. We know from kind of first-hand experience that if we deliver reablement service in people's own homes, they get better outcomes. 80% of people that use reablement at home stay at home. About 50% of people that use reablement in our beds go home. And so I think when we were looking at this package of changes, we felt that the risk of not doing anything for older people could be higher than doing what we're doing. And I think that probably played into the rationale around our scoring. With regards to the care markets,
We, in addition to making some changes around community hospital beds, we, in the local authority, we changed the way that we commissioned some of our beds to support the spot purchase pathway 3. So we used to have a lot of block contract care homes, and we reduced that block contract mechanism so that we could spot purchase instead. So that means when someone needs a care home when they're leaving hospital, we can spot purchase a bed in a place at a time that that person needs it, rather than always having 10 beds over here. So in changing the contract, we identified that there could be a risk to business continuity for the care homes where we were changing block contracts. So that's why that was in there. Our local authority commissioners spent a lot of time working with those care homes that could be affected, ensuring that any changes made were made gradually and kind of in a kind of phased way. So yeah, that's where that came from. And the final point around travel. Yeah. Do you mean for travelling to reach out to people who are having reablement at home after hospital?
Yeah, it's kind of like, so people are having to get to people's homes to care for them. So coming from outside into the homes, there's going to be a lot more people travelling around, and obviously we're a rural county, so that's going to have quite a big impact, I'd imagine.
Yeah. So our reablement service, the lead commissioner is council, and we currently commission 7 different providers that cover our county, and they all have a little cluster, and so they are they're covering their little patch. So rather than travelling from Chard across to Frome, we've got a provider that covers South Somerset, a provider that covers Mendip, and so that reduces the travel down. Whereas if we had, say, one provider and they were covering the whole county, that would be much more difficult to manage. They work in localities. The other thing is the intermediate care services are a real kind of a collaboration between the council and health. And so where possible, we try to avoid duplication. So if we've got a therapist going out, we don't necessarily need the reablement support worker as well. Or if we've got a district nurse going out, we wouldn't necessarily need, we don't need necessarily 3 or 4 people arriving at someone's home in the morning. So we try and be a bit more careful there in terms of our sort of scheduling. And again, that helps with travel.
Yes, you may.
And that's a question I forgot to ask earlier as well, the new one for Burnham and Sea and Crewcare, is that intending to start off already with a 12-month period for test and learn, or will that be 12 weeks and then move into a longer period?
So I think what we have learned from the first sort of test and learn is that 12 weeks isn't really long enough, and it doesn't give you seasonal variations. So we would be proposing 12 months for Burnham, Sea and Crewcare. But happy to come back after a 3-month period and share data as we have done kind of today.
And just the first point that I made, if I may, about in terms of reversing any changes if it proves necessary.
We've said that all along. So these are temporary changes. They are not permanent changes, and recognising the point that obviously if we do put additional services in, we will need to consider that at the end of the test and learn about how we could manage that if we did need to reverse the changes. But just to be brutally honest, these are temporary changes.
Sorry, if I may, can I request that we get more of updates ongoing in terms of the care home provision and that stability and how it's being monitored and progressed over the next 12 months?
I think what we'll do is we'll ask you, I think 6 months, not 3 months, but I think perhaps oh yes, thank you, Emily. I think to come back. I just wanted to make one point before I go to Emily. This is nothing new in a sense to us. This is in line with Somerset's health. This is what we've advocated. This is what we're all working towards. So this is not a new thing. We're just working hand in hand, in club together, working for the same progress, which is what you're trying to do. So I just want to make this is nothing new. We're not voting on something new. This is us working together. So Emily, can I go to Emily? Emily Ford.
Thank you, Chair. I think it would be really welcome to bring this back, as you say, councillor Bruce, and to keep that sort of oversight, that robustness, that scrutiny. But what I think would probably be really beneficial is to have a joint approach and a joint report from both the local authority and the NHS, because it's so intertwined and it's so dependent on each other. And as Kate has advised, that Pathway 1 is commissioned and led by the local authority. We've got spot purchasing beds within Pathway 3. So I think actually having that joint approach would provide the committee with a bit more reassurance as well. So I think if we could probably do that in a joint way.
Yes, I totally agree with that. I think we have to give you enough time to gather the information and gather what's going on. So thank you. Can I go now to the very, very patient Councillor Govier that's online, please?
Thank you, Chair. And like Councillor Power, apologise that I can't be in the room today. Can I just say it's interesting to follow Councillor Wale, because his comments I'd like to echo really. Wellington is obviously mentioned in the report as one of those areas that has sort of, if you like, been at the forefront of getting this type of change going on. And I've got to say that I think I expressed the view the last time this was discussed at committee that those changes have been extremely welcome, and subsequent to the last committee meeting we had a town council visit to the community hospital in Wellington. Sorry, I should have said Councillor Andrew Govier from Wellington. I meant to say that before I spoke, so apologies. And that visit was very useful and did enable people who were had been sceptical about the changes, and when we discussed it, the town council had been sceptical about the removal of the beds, albeit initially on a temporary basis. We're now very positive that the community hospital had changed from something which had sort of under capacity and was being used by a relatively small number, albeit important number of members of the community, to now being something that was a very vibrant facility, which was providing all the things that people have been saying about to do with cancer treatment and a whole plethora of different treatments. So it really isn't something that I think people need to be concerned about. I do think it's one of those things. I understand we were concerned the fact that the loss of the beds, but the fact that those beds are being replaced by care home beds means that people can still be placed where necessary in facilities which are closer to their friends and family. The one issue I wanted to raise was to do with the setting up of the local stakeholder groups, which I think is a good idea, and I think it's on page. It's on page 57, which is to do with the setting up of neighbourhood stakeholder groups. I think it's incredibly important that that we try to forge links with the GP practices, certainly in the local community, because it seems to me that so many of the services, it's always been slightly difficult because the services are slightly fragmented between GP services and the other NHS services because of the structure. So it would be really good to get engagement from GPs to ensure that the services that the people of Wellington or any other community in Somerset need are provided either at the GP practice or at the community hospital, where they can be, accepting that some stuff will still always need to be delivered at places like Musgrove or Yeovil. So it's just really to seek reassurance that we will try to get GP involvement on the stakeholder groups. Thank you, Chair.
Thank you, Councillor Govier. That's a very, very good point, actually. We all want to be working on the same team. We all want to be working together hand in hand to get progress. I think that's very important. The one thing I just wanted to add as well is that it doesn't stop somebody from going back in a nursing home, going home. The system that you have is like when somebody does deteriorate, unfortunately, and then need to be in a nursing home, they can go back to a nursing home. So I think people need to know it's not the end of the story. If they need nursing, it's always there. And my personal experience of my neighbour was that in the end, they got 24/7. They changed to 24/7 care because rather than go in, he didn't want to do that. So he had the 24/7. And this is about choices for people, the end of life, being able to decide what they want. And I think that's vitally important that we understand that, you know? Okay, well, thank you, everyone. I think we've really debated this long, and I think it's been I think the report was very good. I think the report is very good, I should say. I think you have got lots of elements in there, and I think sometimes you need to read it and get in there. But we have a recommendation, members, and the recommendation is that we're requesting the Scrutiny Committee to endorse the recommendation of the extending the intermediate care test and learn for 12 months and implementation of the test and learn in Burnham, Burnham on Sea and Crewkern. Do you all agree? Could you just can I just have a show of hands, please, that you're all happy with that? Thank you. Anybody not happy with that? 2. Your abstentions. Are you abstentions or you're against? You're an abstention. Councillor Storm is an abstention, and the other 2 are Councillor Ewan and Councillor Sully are against. Thank you. That is clearly carried. So, so I want to thank you today. We wish you all the very best of luck, but we do want you to come back to us, obviously. And I think that's vitally important that you come back, keep insight to what we're doing in Somerset, what you're doing, and then that will give us even greater confidence to the members who perhaps are a little bit anxious about it. But thank you for your time today. I really appreciate it. Thank you. Thank you. On to the next item now, please. Can you take your seats, please? And this is for item 7. This is the Somerset Public Health Report, the Miracle Cure, physical activity for all. Just up my street, this is. Yeah. Councillor Cameron, could I ask you to take your seat, please?
Probably what we all should do is stand up and stretch.
Yeah, I was gonna say that.
Yes, we'll do that now. Everybody stand up.
Yeah, really. Very good. Brain's doing it.
Brain flight's good on.
Your card's not come to the camera.
I'm allergic to dairy, but even I have to succumb. Sorry. To chocolate, I mean. And Malibu. Sorry.
We're going to go to Councillor Oaks first, if you don't mind.
Oh, certainly. I was going to do that. That's well done to you. Sorry, well done to you. Thank you, Alison. You're always on the ball. So I'm going to go to Councillor Oaks to introduce, please.
Thank you very much, Chair. Just would say about the exercises, I'm in my care home today, and had you been here earlier, you'd have seen 2 of my residents using the handrail in a corridor like a ballet bar, if you know what that is, for doing their exercises. I've never seen anything quite like it. They were trying to encourage me to join in, but ballet's not really my thing. Anyway, back to the business in hand. So I'm introducing the Association of Directors of Public Health, which we call the ADPH, annual review for 24-25, with particular attention to the findings relating to physical activity. The ADPH report highlights the wider national pressures facing public health, ongoing financial constraints, increased operational demands, and national policy shift, all of which shape local delivery. For Somerset, these themes strongly resonate. Physical activity is central to our prevention agenda, particularly in supporting healthy ageing, including inequalities between our rural and urban communities, there's rurality again, and helping older residents maintain their independence. The ADPH review reinforces the need for long-term investment and cross-sector collaboration to deliver physical activity at scale, noting that genuine progress depends on a coordinated action across health, transport, planning, and community infrastructure. Over to Alison to present the report.
Thank you very much, Councillor Oaks. Thank you. Very, very good introduction there. Alison Bell.
Good morning, everyone, and thank you for inviting me to present my first annual public health report as Director of Public Health for Somerset. I'm joined by my colleague who will just introduce herself. She'll answer all the difficult questions.
Hi, Louise Curry, Public Health Specialist within the team at the Council, with a remit of health inequalities.
Okay, so we've got a few slides and then we're very open to questions or suggestions. So just a reminder, really, there's some slides on the screen if you wish to have a look. The production of an annual report on the health of the local population is one of my statutory duties, and it's part of my role to be an independent advocate for the health of our local population in Somerset and provide leadership for its improvement and protection. And it's a reminder that actually the local authority has a duty to publish this annual report so that people can read it and see it, because it's a gripping read. The topic that I chose for my first public health report is physical activity, which Dame Sally Davis, who was the Chief Medical Officer almost a decade ago now, actually described as the miracle cure, because it has such an impact in terms of preventing poor health, but also helping people live with poor health. So I chose this topic because what I can see is a real decline in the physical and mental health of our population, and also the widening of inequalities. So what we're going to do is take you through some of the evidence and some of the suggestions that we make, and then open questions. But what this presentation really does is illustrate how physical activity can prevent disease, which we really increasingly need to do, and help manage physical and mental health conditions. But when I talk about physical activity, people often say to me, oh, well, I'm not really into running or cycling. We're not talking about everyone joining Councillor Hobbs on his park run or me on my 10Ks. It is absolutely about just getting people to be less sedentary. It's about all of us, particularly once you get over 50, doing more strength and conditioning. It's about doing DIY, doing the gardening, taking the grandchildren for a walk, whatever it is, but it is just building in more activity and less setting in our lives. So we're asking you to scrutinise the recommendations and to support the work across the council and across the whole system to get Somerset moving. And why we're asking you to do this is physical activity is a major driver of health outcomes. So if you look at the screen, what you can see is if people meet the physical activity guidelines, which is, looking at Louise, 150 minutes a week, they have a 40% reduction in the chance of developing type 2 diabetes, a 35% reduction in the chance of developing cardiovascular disease, depression and dementia, 30% reduction, joint pain, which I think we all get a little bit of, 25% reduction, and a significant reduction, 20% in the risk of developing some cancers. We also know if you go for a walk or if you get out in green spaces, that actually you feel better. It helps reduce anxiety, reduces the risk of depression, and it reduces obesity and osteoporosis. So there are so many benefits of physical activity. I really do believe it is the miracle cure. It's a silver bullet, but I can't sell it. So we have to get everyone to play their role. And this is my last slide before I hand over to Louise. So when we talk about physical activity, it seems like an enormous challenge. Where should we start? And so in the report, what we articulate is 3 areas of priority. And I'm going to talk a bit about the first area of priority. The biggest benefit we would get for our population is to get people who do pretty much no physical activity at all. So 20% of our adult population do less than 30 minutes physical activity in a week. So that means, trying to do the math, so that's like less than 5 minutes physical activity a day. and 20% of our adult population are not doing that. And physical activity doesn't exclude people in wheelchairs, doesn't exclude people with disabilities. You know, people can still be physically active. So where we want to put most of our energies is with that 20% of people who are not physically active at all. And the biggest gain, so on the graph, what you can see is the biggest health gain, the benefits is the graph line going up, is for those people who are completely sedentary and get them doing something. So going from less than 5 minutes a day to maybe 10, maybe 20. And they'll get towards that 150, which is 30 minutes, 25, 30 minutes a day. That will really have an impact. And to really have an impact, people need to be walking briskly or taking physical activity that means you can't really hold a conversation. Is that right? Right. Just checking. So that is really the challenge. And Lou is going to take us through some of the other activity data and also some of the benefits of physical activity.
Thanks, Alison. The current trend for physical activity data, both nationally and for Somerset, is being displayed on the screen at the moment. And this is the trend of physical activity levels in adults for the past 10 years. So to the left of the graph is 2015, 2016 data. And to the right of the graph is our most up-to-date physical activity data. As you can see, that trend has remained fairly consistent. So the positives are that we don't have a decrease in our physically active adults. We are maintaining a similar level to the Southwest region and also a national context as well. However, nationally, we are performing very poorly. So that is just an infographic just to show where we are in line with the national data and how we have remained for the last 10 years. So the current situation in Somerset is that we are performing poorly. The whole nation is performing poorly and there is work to do. It's a very scary place for people to start increasing physical activity from a sedentary position. And I think our stance needs to be that we encourage and promote activities of daily life, better known as ADLs, which can be physical activity that involves activities such as hoovering the house, changing bed sheets, doing some gardening, lawn mowing. All of those will contribute to the recommended physical activity guidance set by the CMO. So just from a birth to death image there, we've currently got 50% of children that are meeting the recommended guidance for physical activity, 69% of adults aged 19 plus. And as we go up that age spectrum, 53% of adults aged 75 to 84 that consider themselves to be physically active. And then that drops to 31% for those who are aged 85. And I think it's a really key point to be mindful of the fact that projected age trends in Somerset between now and 2041 is that our ageing population will increase by 31%. I paused for effect there.
If you wanted a,
I did
yeah,
that.
sorry,
Yeah.
sorry. I didn't get the email, sorry.
So in April last year, NICE actually produced some updated guidance to help support active ageing and physical activity, and acknowledging the impact that falls assessment and strength and balance and falls prevention will have on our ageing population, starting in a position of what's known as prehab, which is a preventative activity before we have to then start launching rehab services. For those people who have had falls, are subject to long lies, who can't get themselves off the floor, who have had knee or hip fractures due to a fall. The NICE guidance would greatly improve those chances of older people improving their physical activity levels and having access to tailored services that would support that healthy ageing and that longevity of life. So obviously we've discussed the benefits of physical activity and the miracle cure, but this is a really impactful graph that demonstrates decline of a person's ability to be able to get themselves to the toilet and not get themselves to the toilet, using the factors of having an onset of health condition whilst remaining physically active, and the onset of a health condition in yellow and not having that level of physical activity that has been worked out over the years. And as you can see, even the onset of a health condition in an aging population would still be able to support an older person to retain their independence and improve their health functions. Whereas what we're seeing in that population that doesn't have access to or doesn't participate in any kind of physical activity intervention tailored for aging population, a very fast, rapid decline into losing their autonomy and losing that ability to remain independent and resilient for as long as they possibly can. And I think we also need to focus really strongly on the population need. We need to take into consideration our inclusion health groups, our health inequalities and our protected characteristics, and try and create an environment where health equity is available to all. Through the Active People Active People's Survey in Somerset, we were able to keep on top of and monitor data from our residents' health and inactivity levels. Now, we've maintained a balance since 2015, and as I've already touched on, we need to start looking at those inactive populations, look at what type of demographic they are from, and working with the relevant agencies to move forward, increase accessibility, increase opportunities, and actually get some movement happening. Collaboration and joined up working is very key in everything that we do in terms of physical activity. And it's not just the typical sport and physical activity operators, such as leisure providers, Active Partnership and Sport England and our NGBs. We need to be looking deeper into place-based community hubs and groups that identify the people that they know best within their local areas and take that activity out there and increase accessibility options where they could either attend something like our proactive exercise on referral scheme, access one of our many health walks that are available across the county. Last quarter, we had about 25,000 attendances at our free health walks. Those are staged for levels of ability. Those are available across the county and accessible to absolutely everybody. Very social as well. We also need to consider and factor in how we improve accessibility for our disabled populations, our unemployed, and our core 20+5 populations, which we're currently looking at through place-based partnership and coastal partnership work with various partner agencies as a collaboration.
Okay, so if we go to the next slide, we have nearly finished talking. But so there's quite a lot of detail in the report, but I think what we're asking Scrutiny for is to add their weight to the 3 areas of priority. I think what we articulated in the short term was very much getting that section of our adult population that are not active at all mobile, because if we can get people active in their 40s and 50s, then actually we will delay potentially their career as potential dependent service users in the future. In terms of the medium term, we want to, as Lou described, look at this more in terms of a lens of health inequalities and try to target groups at greater risk of inactivity. And we know female participation in sport really drops off in secondary school, and post-16 education off a cliff. Just don't do it anymore. There's lots of other groups of our communities who have protected characteristics who are also have a range of barriers that we need to explore in more detail. And longer term, I think, and this is very ambitious, we need to ensure physical activity is initiated and sustained across the life course. And And that starts very much at the beginning. What you see parents do is what children do, and what children do is how they live their lives as adults. You know, we default to car use if we can afford to run a car. We need to default to active travel. We need to default to walking and cycling. And yes, it takes a bit longer, but we need to factor that into our lives. So those are the three priorities. If we go on, there's just a few resources. Lou mentioned a few of these. If you would like more information, we have the proactive exercise on referral scheme. We have Somerset Health Walks that anyone can sign up to. There's a falls prevention programme. There's an activity finder through SASP, and there's also a sports club directory. So we're not starting from nothing. We have a really active Somerset activity and sports partnership that is led by a voluntary sector partner. And what we need to do, though, is embed this across our system, not just rely on SASP to lead this. Next slide. There's a few resources that you might want to explore outside this committee. And the last thing I'm going to close with, next slide, is you'll remember that last year I presented Trudy's last DPH annual report, and I think it's important, that was on smoking. It is important for you to understand that when we come and present our annual reports to you, we don't walk out the door and do nothing. So what I've presented is an update against the recommendations that we made last year. Councillor Oakes has been a huge champion of our Stop Smoking initiatives. It's been on the radio countless times, but we have some really good regional and national leading work now. So our schools resource for being smoke and vape free has recently been showcased as best practice in the region. We have the highest quitting rate of smoking in the southwest of England. And we've had a really targeted outreach offer to people supported in social housing and also people supported by a drug and alcohol service and homeless people, which I'm particularly proud of. We also have invested in trading standards so that they tackle the illegal tobacco and vapes activity. We can't do that as a council, so we invest in trading standards because price is one of the ways we've discouraged people nationally from smoking, but you can get cheaper alternatives illegally. So by shutting that off, we help support people stop smoking. So there's a few headlines of the work we've done since last year's annual report. And rest assured, if you endorse recommendations of this miracle cure annual report, we will get to it and progress the work. But I think, as Lou said, the thing about physical activity is this really relies on community infrastructure to get behind it. And actually, with our shift towards neighbourhood working, there's something that councillors can do. There's something that we can all do in our local communities, you know, advocating for walking to school paths, walking buses, cycle routes, in your planning capacity, when you sign your planning applications, make sure there's some active travel infrastructure built in, and you can even participate in stuff. So we've talked enough, but we'd be really interested in your views. Thank you.
Thank you ever so much. Yes, I've got the councillors down, so I'm gonna, will I get told off here? Right, hang on, sorry. And John Bailey and Lucy. Okay, I just wanted to say, the thing that frightened me most of all about health and about walking was when it was about the stroke. Do you know what, that resonated more with me, and I notice you don't, on your three priorities, I still think that's a frightener. I still think that's a good one to mention the health issues. Maybe I've missed it. I'm just looking at them now and it doesn't seem to me strong enough, if I may say. I remember my mother had a terrible stroke, really bad 4-day stroke, and she was unable, she had such high blood pressure, they stopped her from walking, and she loved walking. So it was a kind of a chicken and egg. But I know when I broke my leg, which everybody's heard about, fed up about 18 months ago.
Did you?
Yeah, sorry about it. I was so depressed, and I mentally, I was really bad. And they told me at the hospital that many people don't get over it. at my age because physically they can't get up and about afterwards, and I've sort of forced myself a lot to do that. But it made me realise how the physical, as soon as I started moving around, as soon as I said, it doesn't matter if it hurts, I'm going to still do it, I did feel so much better. So I learned that lesson myself. So I learned experience again, but I do think it's important that, but I do think that the fear, the risks to your health, I think is a big, powerful message. And that was something that resonated with me. So I just wanted to, and I just wondered if the recommendation, you know, you've got your aging well and you've got your reduced health inequalities, but I would like to see a little bit more. I would like to see something in there that mentioned about dangers to your health if you don't do this. It's just a suggestion. It's only just me. So just a thought.
That's noted. I will add that in. Thank you.
Thank you. Okay, so we're now going to Councillor Sally.
In the word excellent, I think that public health is a beacon of Somerset Council. And when I question what I'm doing, why am I here? It is a lot to do with public health. It goes across everything. And what you're saying is simple. It's a simple message. It's really important, but it is so important to people's lives. And I turned my life around 2016, early 2017. And what started me off was a ridiculous challenge to learn to dance. And that led to parkrun. Parkrun, you can walk. Many people, many ages, many abilities. Now, currently, my dogs keep every day. I'm out 1 to 2, 3 hours with my dogs. But without that, I would not be the person in front of you because it's a daily need. You work across everything, all our services. You know, this is why it's so important. And I do try wherever I can to highlight what you're doing, but I don't think I do enough. So my question really is, your great work and your initiatives, it does get lost because it's in everything we do. So it's not just one box called public health. So how can we, how do you enable this continuous awareness of what you're doing so it's recognised and valued more at the council on a platform really that it deserves to be? And I can't gush enough really, Alison and Graham with and your team. So yeah, I don't want this to be an annual report, you know, or you to just come back and say this is what we should be constantly thinking about supporting you. I also did the No Dry January as well and had support from your colleagues on that, which was really powerful to me personally, and I spread that message. But yeah, so how can you always be front and centre of our minds? Because I think it's so important what you're doing.
Do you want to respond, Alison?
Yeah, first of all, thanks Councillor Sally for your support. In terms of physical activity, we're going to take this to the Health and Wellbeing Board because we recognise we're a very small team in a very big organisation, in a very big system. You know, we've got 550,000 people we need to reach with this message. We can't do that alone. So I think this is trying to get all of our partners, police, probation, you know, the NHS, education, everyone signed up to the real opportunity of getting our workforce and our population more physically active. And you're absolutely right. Liv's really good, but she's not going to manage to do this on her own. So any support you can all provide, raising awareness of the SASP initiatives and the opportunities in your divisions. But we need the help of the NHS. I mean, Children's Services said to me yesterday, we would never place a foster child, a child looked after, into a foster home where people are smoking. But actually, we regularly place children in a home where no one's taking physical activity. And actually, there's a really good correlation there. And so it's building into our commissioning. Graham's care home, I know I can see Councillor Oakes wants to come in. His care home have the ballet bar and people are encouraged to do physical activity, are we putting that in our commissioning specs for adult social care, that everyone gets the opportunity to go for a walk or do physical activity? So it really is embedding it into every aspect of the council visit and all bits of our system. Oh, and Lucy.
And just to further add to that, we've actually got a Somerset Residents Health and Wellbeing Survey that's launching on Monday, the 2nd of March. So in terms of support, we would absolutely love it if this could be, the survey could be shared with local communities, contacts, and anybody within that to further enhance the level of data that we have on the health and wellbeing of our population within Somerset. We'd be very grateful.
Can you wrap up the comms on this? Is there a plan?
Comms are involved and have been very, very helpful. And I think the success of the survey will be almost word of mouth and sharing from our staff and colleagues. There is a comms plan in place, and we're hoping to get some radio action as well. But just as an aside first, just to make you aware that that's launching on Monday, and any support would be so gratefully received.
Yeah, excuse me. I go to Councillor Oakes as the lead member, just to tell you as well that you'll all be interested to know, we also did dry January.
Well done.
I know, it's just
Well
amazing.
done, Jill.
I know, it's incredible. Sounds like I need one every day, but I don't. Councillor Oakes, looking forward to speaking to you. Come along.
Yeah, I too, my first ever dry January, and it was quite interesting. I also have a reputation for always talking about the Ham Hill Visitors Centre in any conversation almost at all. And I would mention that anyone visiting Ham Hill, where you can get a lovely cup of coffee and educated in our visitor centre, is a wonderful place for exercise, whether you're with dogs or without. There's lots of walking that can be done. I wanted to just mention, go back on the report. I mean, there's so many good points, and I'm really pleased to hear Councillor Sully's comments about the importance of public health. But I would stretch this bit, my reaction to our smoking results. Yes, it's great to be best in the Southwest, but there are 4 authorities that are already smoke-free, and we're not one of them. So we need to push on to be the first smoke-free authority in the Southwest. The ones Woking, Stafford, Rushcliffe and Epsom and Ewell have all achieved it. They're just under the 5%. We need to halve the number of people who smoke in Somerset, and we can do that. And as those people give up, whatever better time than to take up some exercise to replace your buzz from taking in a bad drug to actually getting exercise. So lots of exciting things. The report is a good read. I'm sure you've all read it. But also perhaps try and, like I think Councillor Sully was suggesting, let's spread the word, not just with the survey for next week, which I'm hoping you'll all share via your social media, but also this report. It's a brilliant report. And yeah, if you want to change the future, you change your present. So that's what we've got to do. We've got to make the change now and be more active. That includes me. I've become a fat old bugger. I have to lose some of that. That I'll be doing the rest of this year. So I'm hoping that not to the Edric levels, obviously, but I'm hoping that people will get enough exercise so they don't need those defibrillators we were talking about earlier.
I think you should become a politician, Councillor Oakes. It's very good. Thank you very much for that. Okay, can I go now to Councillor Cameron?
Very much. Listen, indeed, much. You're going to slap me on my wrist now because I'm going to go old school and say 3 pillars of public health, but I won't mention that anymore. And that answers Councillor Sully's point. What I would ask a question on is maybe you heard my question to some of the NHS colleagues previously when I talked about community wellbeing hubs. Do you think that there should be scope in there for community health and wellbeing hub? And that should be the future direction of travel that we should try to urge all of our collective colleagues into.
Yeah, I think I felt very heartened when I saw the new NHS plan. actually, because one of the big shifts we have to make is from treatment to prevention. So it's no good just having treatment services accessible. They have to be aligned with the community, early intervention and prevention services. And I think a really good example of that is the work that Lou leads around exercise on referral. I don't know if you want to talk a little bit about that. If you haven't got time, don't worry. But do you want to talk a little bit about exercise on referral?
Yeah. Can I just tell you though, that is, on referral, it's so hard. But when you're not up for it, I do sympathise with so many people who don't manage it, because I've been one of them. Just wanted to say that.
Completely understandable. So our proactive exercise on referral scheme is a commission service that's delivered by Somerset Activity and Sports Partnership. And it is a physical activity programme, initially for 12 weeks, based either with an independent instructor or at one of our many leisure providers across the county. You are able to self-refer into the programme. You can get a primary or secondary care professional to refer you in as well, and also health connectors can also refer in. It's a 12-week programme of tailored activity based around your individual needs or your health condition. This has been running since, I think, 1993, and has been a constant in public health and in Somerset for that long. It would actually be really interesting to see how many people have been through that scheme in that period of time. But the work that is currently being done by SAS on the proactive scheme has really broadened in the last 3 years, whereby the number of conditions and the spectrum of the health conditions that are now being accommodated within the scheme have broadened. We've got really good buy-in from primary and secondary colleagues, and are working with them to identify any barriers that are in place currently for people who would like to or who need to attend, to break down those barriers. The scheme is growing very fast, and areas of Somerset that previously haven't been covered are now operating and delivering the exercise on referral scheme for our most immune populations. As part of that contract, the Health Walks programme is also in place for people who may not have a health condition, who may prefer something slightly gentler to launch that journey from sedentary behaviour to that 100 minutes on that curve that Alison talked about earlier in the presentation. And there are various stages of health walks. So level 1 or 1 boot is the easiest on a flat route, no stiles, easily accessible, and the walks increase up a level of difficulty to be longer, including climbing over stiles and walking on uneven ground, tailored for people who perhaps have improved their physical activity to a level that they can take on more adventurous walks, and for those who have been physically active previously and are just looking to maintain that level of activity as they get older. This is hugely beneficial because it's such a sociable and interactive activity as well. And obviously that contributes towards the mental health and social element of, physical activity, aging, and having that barrier to isolation being broken down.
Yes, that's very important, isn't it? Okay, thank you very much. Can I go to Councillor Bailey now?
Thank you, Chair. Yes, thank you for your presentation. It was all very stimulating and I think absolutely fundamental. But I want to sort of just make comments on really 3 areas. One is that the point that Alison made right in her closing remarks on the presentation, that we have an opportunity as a council to look at the big picture and to look at this as integrated across all the areas. You mentioned planning, and we regularly get situations where developers will backtrack on various activities. We've got previous developments in my patch and lots of others where cycleways have been built in, they don't go anywhere, they don't start anywhere. With a small amount of effort, we could join those all up. So it's not a matter of, I think it's a matter of celebrating what we're doing already, which is great. I want to come back to that one if I may. But also just adding to that, and that's where and therefore, I'd really like to see the action plan that takes this forward in some ways at the big level across the council, from the points you made, into areas like planning, into active travel, into buses. And I'd just like to thank Councillor Oakes for mentioning Martock, because Ham Hill is in Martock, and there are about 500,000 visits there every year. It's just an open area, effective, with a lot of interesting things. But people visit it with dogs or whatever. So it's not a matter of having a large amount of infrastructure in some ways, but it is a matter of caring about that. And there have been times over the last 10 or 20 years, sadly I've been around that long, where it has been suggested it wasn't worthwhile having those sort of things. But we have a lot of open spaces, I know, that have been found in the integration process gone on, which people didn't really exist. So how do we use those? So integration, of course, and I'd like to see what, I'll come back to the smaller picture now, but the bigger picture is, how do we involve young children, when you made at school? And you made a very good point about with the commissioning, how do we integrate that into there? That really has to happen, take this next step forward, because in some areas, we've got the low-hanging fruit. We need to sort of move up a bit. Some areas we haven't got the low-hanging fruit. Perhaps I'll come back to that in a moment. So it's about the young people, it's about planning, just two of the things you talked about. I'd really like to see an action plan that would integrate this scrutiny group and all the different departments, groups, or whatever we call them now, across the council into this. So I'd like to see an action plan for that. Perhaps on the focus side, one of the questions I was having in my mind coming to these mornings is, what can I do with this information? I would find it quite useful. I know where the health walks are, but I don't necessarily know where all of them are in my patch. And I'd just be interested for perhaps the 110 councillors to think, where are the gaps? Because those are the ones probably we could fill quite quickly, rather than getting another health walk where there are already 2 spokes apartment, for example, and 3 in Martock operating, but to look at the places where they don't exist and how we can use, not necessarily with a great deal of resources, but it will require resources, how the places that in my patch or the other sort of 6 councils altogether, how they could learn and speak just to other parishes and learn by them, and how easy it is to set these things up and how it needs volunteers to keep them going. So big question, what do we do integrated across the council? Second one is, what do I do? And how could I get a map of where there are gaps in my patch that I need to talk to parish councils and put in the reports and look with volunteers about how we can add to those. Thank you.
Thank you for your comments and your support. So I agree with you. A report's lovely, but unless you turn it into a plan, that's exactly what we did with the smoking one. That's why I can tell you what we did. So there will be an action plan as a result of this. And yesterday I took this draft report to service directors meeting. So Emily was there, but also the economic people, the transport people, children's, the adults. And I said, I need all of your help. And that was where the commissioning ideas came from. So Lou is our point of contact, and she's already connected with the active transport people. And we have to use the whole might of our influence to get people physically active. Most of my time I'm fighting Coca-Cola marketing industry, the tobacco marketing industry, the alcohol marketing industry. So we have to outsmart them, use the resource we have, and commercial determinants even influence active travel. Because if you think about the way cars are marketed, they're marketed as, shiny and fast and sleek, and you're really successful if you have a fast car that guzzles loads of fuel. And that influences our decisions as to how we choose to move around. Anyway, I could talk for this for hours. So yes, I have an action plan, and it will be across the council. And I am going to children and family scrutiny as well, because this is a people's service. One suggestion, Councillor Slocum, is just to pick up Councillor Bailey's point, is maybe we could do an all-member brief around the resources around physical activity, so that you can look where the gaps are, make suggestions to us, and then we can work with SAS, couldn't we? So, because if you can find volunteers, we can train them through SAS to lead health walks, and there we've got a win for, you've got a win for your division, and we've got a win for our population's health. So I think we'll definitely take that forward if you're willing to support.
Yeah, I think that's an excellent, sorry.
I was just going to say, will it be in our outcome tracker?
Yes, we'll make sure it's in our outcome tracker. Jamie's typing it as we speak. The other thing I was going to say is that you're doing children's. There was a campaign a long time ago about children who lived a mile from the school to walk to school when my children were at school, and they got a kind of a star at school or some sticker or something, I don't know. And they walked to school and they were able to show. I'm sure the trainer industry has helped with the walking, because we all buy these fabulous trainers that cost the earth, and you got to walk in them. So it is lovely, but I do think we could, if we could encourage our young to understand jumping in the car isn't always the best idea. Walking to school, just walking to school. And I do understand parents are anxious. I get that anxiety, but our children won't need to learn to live in this world if they don't experience it. And I just think there's a pronged approach. So anyway, that was just my little thing I wanted to say. Can I go to Lucy as a tremor, please?
Thank you, Chair. Thank you for the report. It's always really interesting to read these reports to see what work you're working on next. I do miss public health. Now, I do have a few questions. So I've got a couple of sort of specific questions, and then a general point I want to make. The first thing I want to say is actually I've had the most sedentary week I could ever have had, with so many meetings, so many papers to read. You know, I really feel it. My hips are sore, my lower back is really sore. So I do support this, and I do understand that, you know, I understand the importance of exercise, but it's trying to fit it in to make it a regular thing, because every time you have to start again from the beginning, you know, and build back up, that's a real challenge. And it only takes people to be knocked out by an injury, by even, you know, a pull or a tweak, this or that, you know, and it